We should be live now.
Very good. Welcome back, committee. And we welcome Senator McEwen, who was out with technical difficulties this morning. Welcome back. We're going to follow the same format we had this morning. We're going to move into a little bit more, a little different subject matter this afternoon. We're going to start with DFS, and then we'll move into the hospitals and talk about billing, hospital cost, et cetera. But we'll start off with DFS, and I see Corin Schmidt in-house, and I'll bet she's going to talk with us. So the floor is yours. We'll wait until she's done presenting committee, and if there's any specific questions about her presentation, we'll go ahead and ask them at that time. So just save them up. Corin, the floor is yours.
Thank you, Mr. Chairman, Madam Co-Chairman Wilson, and members of the committee. My name is Corin Schmidt, and I'm the Director of the Department of Family Services. And thanks for giving us the opportunity to talk a little bit about our agency and what it is that we do. We're taking a little bit of a different approach to our presentation than we have in the past. Joining me today is Lindsay Schilling, who I think will be showing up briefly. But between the two of us, we're going to walk you through the continuum of care provided by the Department of Family Services. The outline of the presentation will follow the report that we submitted to you. So we took a different approach from health in that we put together a report that you can use for a variety of reasons. The PowerPoint that you have will then point to the pages of the document. The reason why we're switching it up a little bit is that in the past, we talk about our programs specifically in terms of the work they do in the division. But if you look at the work that the agency does and the money that it spends, it really is around a continuum of care for the well-being of children and families. And it's important for, I think, all of you and certainly for the general public to understand where each of the dollars that we spend come into play in terms of supporting the well-being of children and families. So if you have any questions, certainly as the chairman said, we can wait till the end, but I do hope that you can kind of have a visualization of the presentation in terms of a community, what's available in a community that's supported or directly provided by the Department of Family Services. From the very beginning, when a family maybe needs a little bit of additional support with food or with some sort of work program, all the way to the part of our agency and the work that we do that is maybe more familiar to you, which is where we're really invested into families who whose children maybe have been abused or neglected. There may be a juvenile delinquent, or there may be a child in need of supervision. So with that, Lindsay, if you would like to start the slide deck. Lindsay Schilling is the Senior Administrator of our Social Services Division. And the request from Chairman Wilson was really to talk about children who are typically in care or children that need treatment. But it's important to note, as I said, that there's a process by which those families engage with us, and we want to be able to explain that process to you. So next slide, please. All right, why home matters. As we think about the services that families need, what we all really want is for children and adults to live safely at home. Having children in care, having elderly people having to leave their homes is really a tough part of their lives. So if there's a better way that we can provide those services so that children and adults can be safe in their homes, that's really what we're aiming to do. We also believe that every family should have an opportunity for success. A big part of our responsibility as an agency is to understand what opportunities are available and to help the family, to help the vulnerable adult understand and know what is available. And then they get to decide at the end of the day what is in their best interest and how do they want to participate. And then supporting the people who support the families. We rely heavily on community partners, on community stakeholders, on other agencies to support our families. And we recognize that this work is hard. So supporting those people who are engaging every day with families with vulnerable adults, understanding that as an agency, we need to keep them at the front of our minds and providing them with the support that they need so that they can continue to do the hard work. Next slide. So just a real high level of what we are from a structural perspective. This reflects after the step 2 and step 3 reductions. So this will be effective July 1st. We have 658 positions total. We have our state office, our field offices, and the boys' school and the girls' school. So we have 2 youth facilities, the Wyoming Boys' School and the Wyoming Girls' School. Of all of our staff, 88% of the positions are out in communities or at the facilities. Only 12% are really focused on program and policy work. The biennium, we have 132.8 general fund and 132.3 federal fund and 10.4 other. So some special revenue that comes into play. We also have some tobacco settlement funds. This has flipped. Prior to the budget reductions, we were more generally funded. Now we're more federally and other funded. So the child and family well-being system, we talk about child welfare a lot. And when we talk about child welfare, we often think about the child who's been abused and neglected. But that's what happens after a series of events. That's not the first thing that happens. That's usually through a continuum. So we're looking at our system in terms of 3 different areas. First, there's the community-based services, which is primary prevention. And what you'll see after this is really taking a page out of the public health handbook around creating an environment where the default is safety and the default is good health. So we support a lot of community-based services, for example, SNAP, TANF, child care assistance, which is direct assistance to child care providers to take care of children with families work, and child support. This collection of these types of services are really setting the tone for well-being for these families. Sometimes families get into a bit of a crisis. These services are there for them to hopefully avert further entrance into what we call our system. However, there are times when families need a little bit more support and it needs to be targeted and it needs to be directed. This is secondary prevention. So we have a smattering of services that we either provide directly or pay for that include funding for crisis beds for adolescents. Across the state, we fund crisis beds that families can use if a child needs a timeout, if they need that place to stay. It's temporary, but it is available throughout the state. Juvenile diversion, adult protective services is a big part of what we do in our targeted and home community-based services. Adult protective services really is around a secondary prevention because we do not take adults into care. So there's a very good distinction there between what it is that we can do for adults versus what legally is available to us for adults. And in this case, it's a lot about service provision and case management.
Corin, I don't want to interrupt you, but a lot of these acronyms, I wonder if you could just spell them out. We have members that don't have any idea what SNAP or TANF, and I see a whole bunch more coming. If you can just briefly just tell us what each of those are.
Sure, we sure will. SNAP is formerly called Food Stamps, Supplemental Nutrition Assistance Program, and TANF, which is formerly welfare, is temporary assistance to needy families. And then when we get into the out-of-home and court-ordered services, there's a page that lists what each of those are and what they're spelled out to be. So out-of-home and court-order services and removals, this is where the courts get involved. This is where there is a lot more involvement by stakeholders and partners in the lives of children and families. Oftentimes it's for treatment for adolescents or frequently because of abuse or neglect of a child. Next slide, please. So primary prevention, these are community-based services that aim to prevent abuse, neglect, or exploitation before it ever occurs. So looking at your document, your report, and the corresponding pages, the primary prevention, which is community-based services and supports, which I hit on already, really involve a whole smattering of programs. Cash assistance, which is what we call POWER, is direct assistance, direct cash payments to families or households based on eligibility criteria. We use federal funds for the cash assistance program. And the grant is called TANF, Temporary Assistance to Needy Families. Childcare is available to qualifying families. Eligibility is based on financial criteria. And providers receive payments directly from our agency for childcare services provided to eligible families. We also provide child support services. We collect and redistribute child support for everyone in the state. We do that through community-based organizations. So each of your communities has a child support office that we contract with, who does a lot of the legal work and the direct case management work with families, with parents, custodial parents and non-custodial parents. Food insecurity, which is something that really was highlighted during the recent COVID events. SNAP, which is formerly food stamps. Individuals received in 2020, $41 million of benefit. We do not receive those dollars directly. Those dollars are issued to cards based on eligibility that is then spent by the recipient. So what we do for this particular program is administrative management. So we get administrative match and we do eligibility and ongoing case management, but the food benefit comes directly from the federal government to the recipient. We provide administrative dollars to the Wyoming Food Bank of the Rockies, and on their behalf, we purchase food. We get money from the federal government to purchase food, which then the Wyoming Food Banks of the Rockies distributes. So they distribute those foods, pounds of food, throughout the state. We also get administrative dollars and some purchasing dollars for the Commodity Supplemental Food Program, which is specifically for senior citizens. All of the senior citizens program is based on eligibility criteria. There has to be documentation or presentation of eligibility. Home visitation, we support the home visitation program at the Department of Health. We provide funding to them, to public health nursing, for home visitation services for new moms, for even prenatal moms, postnatal moms, and young children. We provide federal funds, TANF, the federal block grant. We provide money to the Department of Education, and they in turn purchase preschool services throughout the state at a variety of locations. Weatherization is a program for, there's two parts of this program. One is direct assistance for utilities for energy and utility payments. So for qualifying households, we pay utility companies for rent or for heating bills, all sorts of different kinds of utility bills. This is a federally funded program. And then with weatherization, based on qualifications, we contract with two companies that will go out and make improvements to homes so that they are able to be more efficient with their heat usage. So it may be the replacement of a furnace, it may be the installation of insulation. There's a variety of things that we can do with these dollars. We support work training throughout the state. Some of our contractors include Climb Wyoming, which is a program that's focused on moms with young children and providing them with opportunity for education and training and job seeking opportunities and placement. We also contract with the Uinta Board of Cooperative Educational Services, BOCES, who also focus on work training for mothers. And then we also provide dollars to the Department of Workforce Services, who does employment training for our clients that are receiving cash assistance. Then the Wyoming Children's Trust Fund is an interesting animal. Its budget is within the DFS budget, but it's actually a board that's appointed by the governor, and they receive federal dollars and funding from Vital Statistics. And with those dollars that they receive, they fund local child protection teams, which are groups of people in each of the communities that focus on preventing child abuse and neglect, and a whole host of community-based primary prevention efforts. And we mentioned then we have a lot of partners and debated about how do we include everyone. We mentioned this particular trust fund specifically because they do show up in our budget. So secondary prevention is where we start to get real targeted, and start to see a lot more interventions that that complement what you heard about earlier this morning with the Department of Health. So with that, I'm going to turn it over to Lindsay Schilling.
Thank you, Corin. Good afternoon, Chairman, members of the committee. My name is Lindsay Schilling. I'm the Senior Administrator for the Social Services Division. And I'm going to take over with secondary prevention. So I think as we move into conversations around secondary prevention from an agency perspective, a lot of this work is concentrated in the Social Services Division. These are situations where there's been a risk identified or an acute crisis that has occurred. And really the goal and the role we have in secondary prevention is trying to make services accessible without having to escalate into that tertiary prevention where you have the courts involved. Secondary prevention efforts in our division are funded in part by DFS, but often involve collaborative work between ourselves and a number of our partner agencies. Department of Health and Medicaid is a big player in our secondary prevention continuum of care, as is the Department of Education, the local school districts, and workforce services. So just as a bit of an introduction to the division, we have two really operational arms in the Social Services Division. We have our state team that you'll see kind of represented by the protective services, clinical services, our Title IV program, and then our continuous quality improvement and data analytics unit. And then we have Ed Heimer, who is our field operations administrator that really has oversight and responsibility to support the work of the local field offices. So the way that we're divided, we have 9 different districts across the state, and those correlate directly with the judicial districts. Each district is managed by a district manager who then kind of reports up into the hierarchy. So in terms of roles and responsibilities, our state team really focuses on policy development, procedure development, training, grant management, and then any of the grant reporting requirements to be sure that we continue to receive the federal revenue from all of those different funding sources. And then our field operations team are really the folks doing the work day to day. So again, in our secondary prevention menu of services, the focus really is on trying to provide access to services without court involvement, and maybe in situations that would benefit from a more structured support. So going back to the risk assessments and safety assessments, there's been something that's caused somebody concern. DFS has received that call, and we have an opportunity to offer services prior to escalation. So in this particular arena of services, as Corin mentioned, we have our adult protective services. If I happen to slip and say intakes, what I'm just referring to is calls or referrals to the agency. So for adult protective services, those are calls that we have that come into us. They're screened and evaluated for criteria, whether we can open a case or whether we just need to refer to community-based services. In the last fiscal year, we had 1,875 referrals to DFS, or calls, APS calls to DFS. We average a monthly caseload of 160 APS cases. And really, because DFS is not positioned to ever step in a protective custody situation with adults, our focus in those cases really is on case management. We have some funding to provide some emergency services, and then really just focusing on those linkages to community-based services and supports that can continue to help those individuals. Our total biennial budget, and this is direct services only, it doesn't include our 100 series for our staff, $83,000, almost $84,000, and that's 100% general fund. We don't have any of our federal revenue sources that support our adult protective services program. That's all general fund. Crisis center services. So in most cases, I think in everywhere but Laramie County, our crisis beds are connected to our group home providers. DFS funds 81 beds statewide, 14 individual providers, and that includes 3 beds on the reservation. $117 per day, 365 days a year is what those are funded at. And I think the really important piece to this is that utilization of those crisis beds is not at all limited to DFS involved youth or families. Those are open to any family or any child that meet the specific program criteria, and there is absolutely no court involvement required to access those services. It's a short-term service, 7 days a week for up to 30 days, and that funding stream is just over 50% general fund, combined with some of our TANF federal grant money, $3.1 million in our federal funding. This particular graph is really just a visual representation of our APS calls over the last bit of time here. We watched them very carefully through COVID. So you'll see starting in January of 2020 through current March 29th, the week of March 29th, there really was no significant change in the volume of calls we received from our APS side of the house. So that was good news. These were some of our elderly and vulnerable adults that we were concerned about potentially finding themselves more isolated and at higher risk for self-neglect during some of the pandemic. Additional secondary prevention programs in our kinship support. So when we talk about kinship, that's specifically relatives, grandparents, guardians, anybody who's been positioned as a caretaker for a child, teen, or a vulnerable adult in the state of Wyoming. We have a federal grant that helps support the Kinship Connections of Wyoming program. That's a program that's administered by Wyoming 211. Those services are open to anybody. They really focus on helping relatives and grandparents who are raising children or taking care of adult children. Linked to services, there's some emotional support service available, really like a case management function to be sure that services can be identified in each of the local communities, and then those connections made through 211. We also use that same federal funding stream to support services provided by Cheyenne Youth Alternatives. They have come in and take actually a more legal support perspective to kinship services, and they do a lot of work on the legal side with private adoptions and guardianships. So these are services available outside of DFS to non-DFS families, with the hope being that through some of these services and supports, we mitigate the agency needing to get involved for any reason. Voluntary case plans. So we do have an opportunity to provide case management services or temporary placement through a voluntary case plan. There are two different types of voluntary case plans. We can do a voluntary placement or just an in-home voluntary case. In situations where there's a voluntary placement agreement, these are situations where parents will give temporary custody to DFS in an agreement, with the defining characteristic being that there's no court involvement. Those agreements can provide services to families and placement support for those children for 60 days. And then they're sort of approved on an interim basis up to 180 days. But again, just, if there are temporary crisis situations, parents need help, they don't feel they can care for their children, or they feel they're at risk of potentially abusing or neglecting children, this is an option that we have available without having to go through a formal legal process. We can also work with families for a prevention or an assessment voluntary case. And these are just situations where there might be some needs identified in the household. Maybe there's some income instability, some food instability. We can open a case and create access to services and supports to that family. The kids can remain in the home. That's just a voluntary agreement between us and the family. And again, we can do those without court involvement as well. And then the third category here, support to other agencies and programs. So when we're talking about secondary prevention and access to services prior to DFS involvement or prior to court involvement, the Medicaid waiver programs provide a great avenue to access to services, specifically for our shared populations. The Children's Mental Health Waiver, or the Care Management Entity, provides a mechanism for children to be covered by Medicaid access to outpatient behavioral health services if there happens to be no insurance in that situation, without having to come into state custody. The Interagency Children's Collaborative is actually a group that's whose infrastructure lives in Wyoming statute. We meet quarterly throughout the year, and then we have a couple of sub teams that are working kind of specific case management activities. But this is a group that has come together, a multi-agency group. The Department of Family Services is represented, the Department of Health, most specifically Medicaid, the Department of Education, the Department of Workforce Services, and then there's a governor's office appointee that sits on that committee as well. The main focuses of that group, there are three. The first one is more of a systems of care assessment and ongoing development. So through some data collection and analysis of challenging cohorts, challenging children that we couldn't find placements for, or that struggled to access treatments, we're sort of summarizing and escalating that data to the high level policy group. And they're taking a good look statewide at the system of care and the continuum of care for those children. And we hope to, by the end of this year, have some really solid plans in place for some positive changes that can be made across the agencies. The second objective of that group is more of an individual case management and crisis intervention. So each agency was tasked with creating an internal escalation process. But when we run across these children who we struggle with individually to provide adequate services to, or to make services available, we're coming together as a multi-agency group and providing some case management function to those children. A lot of times this involves, we're looking for an inpatient level of care, either an acute hospital or a psychiatric residential treatment facility, or an RTC that can provide appropriate services to some of these challenging kids. And then the group home payment redesign is actually more of a recent initiative that DFS has taken up about 18 months ago. That conversation started. This was really focused on developing a partnership with our group homes to start, and looking at ways that we can fund services differently to open up access to services prior to court involvement. So I think anybody who's been involved with the labor committee for any length of time has heard about kind of this gap in services depending on custody status, right? So children in DFS custody have access to residential treatment centers and group homes, whereas a Medicaid-only child who's not involved with DFS doesn't have those same opportunities. In this particular payment redesign project, we worked with our group home providers to move away from our per day payment and just agree on a fixed price agreement per month, with the understanding that while DFS kids will be considered for admission on a priority basis, that non-DFS children will also be considered and should be served as well under that same payment arrangement. So that was a really exciting change that we were able to make. As of July 1st, we will have active agreements in place with all in-state group homes, meaning that all in-state group homes have agreed to accept non-DFS, non-court-ordered kids for services under the same payment structure that DFS has in place now, without balance billing parents or Medicaid for the remainder of those services. So what it's done is really open up that group home level of care to non-DFS Medicaid kids. So moving on to tertiary prevention. This is really the highest level of system involvement. And this is where in every situation, in every case, the court is kind of front and center in the lives of children and families. So out of home and court ordered services that result from the removal of children in order to reduce the impact of ongoing abuse or neglect that may have long-term effects. So with tertiary prevention, we focus primarily on the child custody statutes and Title 14. There's the Child Protection Act that focuses on abuse and neglect, the Children in Need of Supervision Act, CHINS for short, and then the Juvenile Justice Act. So what I've done here is just kind of focus high level on some of the myths that we hear about DFS. The first being just a clarification that DFS actually by law cannot take protective custody of a child. In the state of Wyoming, the state agency does not have removal authority. Only law enforcement or a medical professional can take protective custody of a child. And once that's happened, there's a shelter care hearing that's held within 48 hours, during which the court will make a decision about the placement of the ongoing placement and custody status of that child or children. And the prosecuting attorneys in each jurisdiction have full discretion over whether petitions are filed in court and what type of petition will be filed. So once we have a petition filed and a formal court case open, within 10 days, the judge must appoint what's called a multidisciplinary team, an MDT, to the case. Mandatory representatives include the parent or guardian, a child psychiatrist, psychologist, or mental health professional, DFS staff, the district attorney or designee, the child's attorney or guardian ad litem, GAL, any volunteer lay advocates. Most often we see CASA represented, the foster parents, and then any other individuals as appointed by the court. So the really important thing with the MDTs is to understand that they function as the decision-making body for these cases. And really it's kind of the equivalent of a treatment team, in a mental health case. So the MDT will review case information, mental health evaluations, details of that case, and make a recommendation. If the judge disagrees with the recommendation of the MDT, the judge actually has to enter a legal finding as to why they disagree. So in any of our open cases, sort of the power for driving case progress and the major decision making is really taken up by the MDT. Additional things to know about DFS. Not all cases that we have open result in children coming into foster care. Those decisions are made on a case-by-case basis and are driven by safety assessments and risk assessments done at the very onset of the case. For example, at the end of April, we had 1,766 kids involved in in-home cases. So these are cases where DFS does not have those kids in foster care, but we are actively working a case with the family. And then we had 918 kids in an out-of-home foster care placement. So of our total caseload, almost 2/3 of them remain in the home. 1/3 of them come into foster care. If children do come into foster care, our primary goal is to try and place that child with another parent, a relative, or a familiar adult to try and reduce the level of trauma experienced through that process. At the end of April, 28% of the kids that we had in a foster care placement were with relatives, another parent, or a familiar adult. Then if a parent, relative, or familiar adult placement is not possible, we do have a network of certified family foster care homes, and we will look to try and find an appropriate placement in a home-like setting. And that is certainly the preference over a facility or congregate care placement. But when a child or children can't be safely maintained in a family foster home, the MDT may evaluate group homes, residential treatment centers, psychiatric residential treatment centers as covered by Medicaid, the girls' school, the boys' school, or any other congregate care facility where that child can be served appropriately and remain safe. So the next few slides, I broke down kind of our cohorts of children by the different acts, the legal acts in Title 14, and tried to just provide a bit of demographic information about each one of them. So under the Child Protection Act, again, this focuses on abuse and neglect allegations. In state fiscal year 2020, we had 1,531 allegations of abuse or neglect, and 1,166 of those were confirmed or substantiated. Neglect continues to be the highest percentage of our caseload. 67% of these cases come in for neglect, 29% for physical abuse, 3% for sexual abuse, and then it kind of trickles down through medical neglect and emotional neglect. We average about 1,100 cases per month, and I have this broken down. Our average age of our Child Protective Services population is 6 years old. 92% of them are served in family settings, so either with relative or non-relative foster care, but in family homes. Only 6% of this particular population receive care in a facility of some kind. And I think as we talk about connections back to the Department of Health, and I heard some conversation this morning on the mental health system reform efforts, 37% of all the removals in state fiscal year 2020 that we had come in were associated with parent or guardian alcohol or substance use. So we're very excited to be partners at the table with the Department of Health as they look to reform that system to create some different eligibility determinations for the priority populations, and then really working to establish criteria for transitions, throughout the system of care and the continuum of care, from community-based all the way up to acute inpatient, and then kind of back down that same spectrum. So this particular illustration, it's a visual representation of what we've seen happen with our Child Protective Services referrals over the last bit of time. Specifically, we were interested in really closely monitoring March of last year through March of this year. This particular graph we've broken down by referral source. We wanted to understand, as we saw a sharp decline in our number of referrals that came into the agency, which of those referral sources were being impacted the most by COVID. And I think it stands to reason with the closing of the schools around spring break and in March. The yellow bars, which are the educational personnel referrals, fell off almost completely until the schools started going back into session again in September. This next graph just illustrates overall the trends that we are watching in related to our CPS referrals. This matches up with the previous graph and just showing a significant and sharp decline in March of last year. What we're seeing now as of the first part of April this year, however, is that our referral volume is almost back up to normal where it was pre-COVID. I think this sort of combined with some of the other metrics that we're watching, we've not identified any significant changes in referral characteristics, meaning we're not opening a higher percentage of cases based on the referrals that are coming in. We're not seeing any significant change in the type of case allegation. So whether it's a neglect case, an abuse case, no significant changes there. While we also, though, still understand we're in a transition period, and we have certainly a set of data points that we continue to watch on a weekly basis as we start to move back to whatever our new normal will be moving forward. So our next cohort of kids are children in need of supervision. I've just provided the statutory reference there and the definition. DFS averages about 102 cases per month of our TENS kids. Of those 102 cases per month, we see a high percentage of these kids served in our facilities in our congregate care settings. 83% are served in group care, 17% are able to be supported in a family foster home setting. And the average age of this particular cohort is 15 years old and older. So these particular kiddos, these are our most challenging cases. So these are situations where parents have found themselves in situations where they can't keep the kids safe, they can't control them. There's an acknowledgement that there are additional services and supports needed to be able to keep everybody safe. So those children actually come into DFS custody, and the parents end up paying child support for the duration of that case. We do see this particular cohort as our highest needs. And I think in August of 2020, we released a brief just sort of summarizing a case study we did of the last 14, what we're calling high needs or challenging placement cases that came in. Over 50% of those came in through this particular petition type. They were all CHINS cases. What we also see is once these kids come into DFS custody, there are a large percentage of these that then move from a CHINS case type to a juvenile delinquent case type after they act out and get in trouble throughout the course of their time with DFS. Additional characteristics of this particular group, they tend to be older as evidenced by the average age. A lot of these kids we see have dual intellectual disability and mental health diagnoses. They tend to be incredibly aggressive and violent towards themselves or others. And we find that we struggle significantly with finding appropriate placements and programs to provide adequate services and supports to these kids. And then our third major cohort of children under the Juvenile Justice Act. So these are kids who are come into DFS custody after they've committed a crime, and the juvenile court has taken them to be delinquent youth. A few interesting things to know: only youth adjudicated by the juvenile court to be delinquent under this act can be sent to the boys' school or the girls' school. This is also the cohort of children with the highest utilization of facility services, most specifically residential treatment centers and group homes. We pulled that breakdown. 90% of our juvenile justice cases have resulted in kids in group care. Only 9% of them have been able to safely be served in their community. And the average age of this particular group, again, they tend to be older, 15 years or older from an average age for these kids as well. And then local services. So there's just a lot of conversation around the services that DFS funds, and the sort of the magnitude of our YCAPS budget is typically how it's referred. But that particular funding pool pays for all of the services that are provided to children and families through any of the cases that DFS works, whether they're court-involved cases or non-court involved cases. The top services: foster care, adoption and guardianship subsidies, residential treatment center services, group homes. We have some family preservation services or mentoring services. Sometimes we can do parent training. We can support transportation needs. We also cover electronic monitoring devices and services, and laboratory services as they're needed throughout the life of a case, detention center services. And then we do a lot with mental health evaluations and treatment for parents or guardians or other folks in the household that are uninsured or underinsured, who need to follow up with a diagnosis and treatment as part of that case plan. So our total budget in our direct services, $106.3 million per biennium. 65% of that is general fund, 35% is supported through our federal revenue. That comes mostly from our Title IV foster care and adoption entitlement grant, as well as our TANF block grants and our social services block grants. So I think as we get toward the end, what I did in this particular slide is just provide a snapshot of what April looked like for us in terms of children coming into foster care and exiting foster care. We had 928 kids in foster care, so in an out-of-home placement, not in an in-home case. On April 1st, 58% of them had been involved with DFS less than 12 months. 21.7% between 1 and 2 years, and then 12.4% 2 to 3 years, and a smaller percentage involved with DFS more than 3 years. We had 59 children that entered foster care in April. 37 of those kids came from cases that we were already working, in-home cases that changed in some way that elevated the risk and led to a change in custody for those kids. 22 of those kids were just direct system entries, so not cases that were familiar to DFS. We also had 64 children that exited foster care. So 48 kids went from an out-of-home placement back to an in-home situation, and 16 exited DFS care completely. We made $1.4 million in payments for direct services. And then I've just listed our top spending categories there. I don't think anybody will be surprised. Our foster care subsidies, the monthly payments that foster care homes receive for the care of those children, residential treatment centers, group homes, and detention centers. So before I jump into kind of major initiatives or projects, are there any questions on anything that you've seen so far?
Committee, go ahead and raise your yellow hands. I see one so far. Representative Conley, go ahead with the question.
Thank you, Mr. Chairman, and thank you, Lindsay, for that incredible overview. 2 questions on foster care. One is regarding money, and is it my correct recollection that we actually cut subsidies to foster care parents. Can you talk a little bit about that? And then my second question is different, and it is about follow-up on kids who age out of foster care. I know that some states, and maybe you'll be getting to this in major initiatives, but some states are extending certain kinds of benefits for kids who age out of foster care, like education, for example. Thanks.
Certainly, Chairman Baldwin, Representative Connolly. So to your first question, yes, as part of DFS's Step 3 budget reduction plan, our original plan had proposed a 6% rate reduction to our foster care subsidies. 50% of that was reinstated through the legislative process. So the final reduction that will go into effect on July 1st is a 3% reduction in subsidies.
And Mr. Chairman, before you answer the second one, Lindsay, what do you expect to be the effect of that? Less people fostering, just less money that's going to the families that do? More kids that will not be placed in foster care? I'm curious about your expectations.
Chairman Representative Connolly, I think obviously that remains to be seen, and we'll watch it very closely over this next year. But based on initial conversations that we've had with our certified homes, and even some of those that are coming in, I think everybody understands and certainly appreciate the effort that was undertaken to reduce the impact from 6% to 3%. But I've not received any indication, and we'll certainly continue to monitor it, that we anticipate any significant changes in our current network.
Thank you very much. I believe Chairman Wilson, you have the next hand up.
Mr. Chairman, I'm so sorry. I had a second question, which was very different. It was the question about services to kids who age out of the foster system. And in part because I know of other states that now have initiatives that are really targeting this population of young adults to make sure that they're successful. So post-secondary education, for example, is something that some states are providing for these kids that age out. Thank you.
Thank you, Representative Connolly. I apologize. I'm senile. I forgot you had two questions. Whoever wants to field that question, go ahead.
Chairman Representative Connolly, absolutely. And I think with some of the funding flexibility and additional grants we've seen as a result of COVID have allowed us to sort of bolster some of the efforts that were already underway. We have the independent living program. We contract with 4 providers in the state to help support independent living and transition services for those kids that are aging out of care. I know that on the Medicaid side, there was an additional eligibility option created for some extended coverage up to age 26 for kids who are aging out of foster care. And then from a secondary education perspective, we also manage the educational training voucher program. So when we have former foster youth that meet criteria that go into a secondary education situation, we do have funding available to help cover the costs of that educational service. One of the things that we're working through now, we received some additional independent living money, some Chafee grant money through the Consolidated Appropriations Act. Also with a directive that children cannot be forced to end their relationship and support with DFS simply because they turned 18, especially during a pandemic. So we do have some funding and we have processes set up, and we're actually seeing some utilization of those opportunities now. But children who opt to, once they turn 18, can come back to DFS on a voluntary agreement in a voluntary situation. And we can continue covering foster care subsidies if they're staying with a family that they want to stay with. We can continue providing direct service support, and all of that is being funded from that additional grant that we got as a result of the COVID appropriation. So that's been incredibly helpful too. Did that answer that question?
Yes, thank you.
Okay.
Thank you very much. Now we'll move on to Chairman Wilson. Are you still with us? Go ahead.
I am. Thank you, Mr. Chairman. Lindsay, I remember a few years ago when I was on appropriations, there was a couple of days in various testimony where it really seemed like some slowdowns or blockages in the court system were kind of rolling back on DFS and maybe making children stay in foster care longer than necessary, or I don't remember all of the consequences, but could you just talk briefly about your interplay with the court system and whether, whether COVID specific or not, but how we need to see that interplay when we consider the courts?
Chairman Baldwin, Co-Chairman Wilson, I might take the first part of that, just COVID related, because I've been around for that, and then might defer to Corin for anything kind of prior to my partnership or employment with DFS. But COVID related, we have been carefully tracking some of our cases, and because the courts went to a virtual platform and they started triaging the types of cases that they were addressing during that time period, we did see some of our cases slow down, just in terms of the permanency hearings. Termination and parental rights cases have been delayed. So certainly I think we're looking forward to getting back to a more normal process with the courts in those particular situations. But I think prior to that, Corin, did you have anything on that one?
Mr. Chairman, Co-Chairman Wilson, I'm trying to recollect what that maybe was about, because that was 8 years ago. How long ago was
Yeah,
that?
so let's see, 17, 18, maybe 2018, somewhere in there. And it seemed to me that there was a discussion, and I was thinking that it wasn't so much a presentation of any one agency, but over the course of, like a day and a half of testimony, we heard from, and I don't know if it was, the district attorneys and you folks and the courts, and it just seemed like, and so this was obviously before COVID, but it seemed like there were some real slowdowns or limitations on the court's ability to process some of the cases. And my recollection was that there was some sort of, whether federal or Wyoming statutory limitation to how many days children were supposed to be somewhere, or how soon you were supposed to resolve some issue, and that it seemed like things were kind of piling up. And I don't know if, I guess if it doesn't strike you, maybe it's resolved, I guess, but.
Well, Mr. Chairman, Madam Co-Chairman, I'm not sure it's been resolved, but just then I think I know what you're talking about, so I'll try to take a swing at it. The Department of Family Services, under our agreement with the federal government, really looks at outcomes of a child welfare system. And one of those outcomes are the time a child is in care. And there's federal law that says that a child who has been in care for the last, I think, 14 out of 22 months, there's some formula that says the state then really needs to come up with a permanency plan for that child. So the overall thinking is that children shouldn't languish in care, that children should have permanency in their lives, and that the law gives us a certain amount of time to try to get there. So we partner closely with the Children's Justice Project, which is in the Supreme Court, to continually work on educational opportunities for judges, for county attorneys, for guardian ad litem, for anyone who really has a key role in the juvenile court system, so that we're doing our best to make sure that children do have permanency in their lives within the time frame. Sometimes in some jurisdictions, it's a different strategy than others. I don't recall any particular cases, and I was at the Department of Health when I think during that time. So nothing is striking me, but certainly it is a continual quality improvement area for us that we're always looking at trying to reduce the amount of time a child just languages, whether that's they don't have guardianship or they don't have adoption, or our preferences is that they are able to return safely to home.
Thanks, Corin.
Very good. Representative Flitner.
Thank you, Mr. Chairman. And just to tag on to those questions with regard to foster care, and if there's a place on the website I can actually go to where I can just find some of these answers, if that's easier for you. But I was just curious about the number of foster care homes we have across the state and how difficult it is to try to find foster homes and what's involved with that. Also, group homes. Does every county have a group home? And then if neglect is if that's the reason for most of the children to be removed from the home, is that a new wrinkle, or has neglect always been what's been behind children having to be taken from the home? And I was just curious if there's anything we can do as policymakers to try to help with regard to that problem. Thank you, Mr. Chairman.
Mr. Chairman, Lindsay, if you have the foster care data, you can present it. If not, I can find it. And also the group home data, the number of group homes and where they are. Representative Flitner, the issue of neglect is perennial. That is not anything new. And that really is one of the major reasons why we're focusing on why home matters and those primary and secondary interventions, because typically what we're seeing are children are neglected, and sometimes it's severe neglect, and it could be because of parental substance abuse. But something interesting that has resulted from the conversation around COVID is that there's really a strong connection between neglect and poverty. And so many of the children that come to our attention might be because they're homeless, living in cars, maybe they don't have food at home. So by focusing a lot more energy on those conversations about getting families what they need before they get into crisis, especially because of the number of neglect cases we see, we're hoping that that's the conversation that will turn our system around a little bit to really be more community-based and not reactionary in a way where children then are removed from their homes. Once a child is removed from their home, first, the very act of removal is incredibly traumatic. And so there are long-term implications to that. And I know in some cases, safety is paramount. Absolutely, those children can't stay at home anymore. But because of the severity of the trauma of removal, we want to really make sure that that is exactly what that child needs. And if that child needs stability in a home setting, and the parents need support with housing stability, then that's the conversation we should be having with the family rather than taking the child out and then having the conversation. And that's a trick and a balance, and it's risky. As Lindsay mentioned, there's a huge focus on risk and safety assessments because we want to be sure that children are safe at home. But certainly I think there's more opportunity to talk about the impact of poverty on neglect, or with more so than intentionality with harm. And then I'll pass it back to Lindsay to answer your first two questions.
Thank you.
Thank you, Corin, Chairman. So I have the data here, state fiscal year 2020, on the number of certified foster care homes. We had 449 certified homes total. 296 of those were non-relative, 110 of those were relative foster care homes, and then 43 of those were specialized foster care homes. So in terms of specialized homes, those are homes that have gone through an additional level of training to be able to take care of some of our high needs youth, medically complicated or behaviorally challenged children. And then I'm pulling up our residential bed map. So we have 16 group homes, and they are not in every county. Our group homes are situated in Albany County, Carbon County, Sweetwater and Uinta, Teton, Fremont, Park, Bighorn, Sheridan, Natrona, Converse, and Campbell counties.
And Mr. Chairman,
Go ahead.
thank you. And with regard to the group homes, is that something that, is there a need for those in each county? And is cost the driving factor in why each county is not represented? I'm just curious.
Chairman Representative Corin, I might defer to you. I know it was a residential bed count study, and I'm not entirely sure if that was residential treatment centers, if that included group homes. But right now, I know the group home facilities are run by private providers. So I'm not sure I can speak to the need in every county.
Okay, thank you. I appreciate it. Thank you, Mr. Chairman.
Very good. Any further questions, committee? I'm trying to flip through everybody and looking for hands, and I don't see any at the moment. Still not seeing any. I'll flip through one more time. It's your last chance. I feel like an auctioneer. For those who are interested, there's 40 people watching us right now. So we've got interested. When I turned it on, there were like 28. So you guys must be doing good. So Lindsay, we'll turn it back to you with no further questions right now.
Thank you, Chairman. So this last slide, I just, if time permitting, wanted to take an opportunity to kind of talk about some of our major initiatives over the course of this next year. With our primary project being our case management system replacement, our YCAPS replacement project. This has been a big conversation with joint appropriation, but essentially we have, I think as many state agencies do, an outdated IT system that really during the course of COVID came to the forefront in terms of operational support and improvements that were needed to continue doing the work that we do. We also are sort of facing implementation of some new federal reporting requirements for next year that our current system is not going to be able to come into compliance with. And we do know that at some point down the road, we expect there to be financial penalties or withholds to some of our 4E reimbursements if we continue operating with a system that's not federally compliant. So we were through this last legislative session given just a little bit of money to continue some of our planning work over this next year. We do hope to release an RFP in the next month or so, and then come back to joint appropriations in the committees in November and December with some updated project estimates on what that might look like moving forward. So that's a big undertaking right now for our division. The second one is related to the maternal, infant, and early childhood home visiting grant. So this is a federal HRSA grant that has historically been awarded to parents as teachers at a corporate level as a nonprofit. And that money has gone to support services provided by the Citizen Review Panel and NowCap in terms of the Parents as Teachers program. We're just looking at transitioning the oversight and administration of that grant from Parents as Teachers to DFS. So we have a grant application going in just about 30 days to make that change. We're not planning or anticipating any changes in support of those services or programs. Currently, we're really just focusing on the oversight. But I think the exciting part of that is looking at opportunities that we have coming up with our Title IV prevention plan and accessing some additional federal revenue through that program for approved services. It's a really opportune time to look at potential blended funding opportunities, program expansion opportunities, and so forth. And then our Title 40 prevention plan. Again, this comes out of our Family First Prevention Services Act, passed in 2018. We've worked the last several years to implement all of the mandatory requirements that were part of that federal legislation. The last of those will go in on July 1st. And then at that point, we will be positioned to look at additional opportunity and things we might be able to do through the prevention plan in terms of leveraging some additional 4E revenue through that mechanism as well. So I think lots of really interesting opportunities coming up. And I think in listening to Department of Health, they set the stage pretty clearly in several of those conversations, just in terms of kind of the focus that we're taking on mitigating risk and trying to prevent those tertiary prevention interventions, just because we know it lessens the trauma impacts on children and families. So that's been really exciting over the last several months. Corin, did you have anything to add to any of those?
No, I didn't. Well done, Lindsay.
And that's all I had for today.
Very good. Committee, you have any further questions? Put up the yellow hand. I'm looking through again. And while I'm flipping through, I would tell Lindsay and Corinne how much we appreciate these presentations. Certainly we'll see you a lot in the coming few months and years, et cetera, but we appreciate your taking the time to be with us today and give us some concrete base to work on as we go ahead. Thank you very much. It doesn't look like there's any questions. Committee, what we're going to do is we're going to take about a 15-minute break here to give the Hospital Association time to brush their hair, maybe have a drink of water or a drink of whatever they want to drink. So we'll plan on being back in here at 2:30, and we'll restart again with the Hospital Association, talk with hospital costs, critical access hospitals, et cetera. So we will see all your bright, shiny faces in about 15 minutes at 2:30.
Hey Kathy, how's your knee doing?
Hey, Dan, you know, I got a gel injection on Monday, which was painful, but right now it's amazing. So I'm really fingers crossed that it's better.
Oh, wonderful. Well, we missed you yesterday at the WRI tour. That was amazing what's going on there. Yeah.
Well, I've known Michelle Holmes for years, and she wrote back to me and said if I want a private one, she's more than happy to arrange it. So I'm glad it was interesting and good.
Yeah, it really is.
Chairman Baldwin, just want everyone to know we're live on YouTube.
Very good. I was just about to say that.
Oh, so the world knows about my knee. Sorry.
No, just the tail end of it, Representative Conley. You can share it at the end of the meeting if you want to tell us again. Welcome back, Betty. We're going to move into the final portion of our meeting for the day. That portion would be the Hospital Association is going to share with us today. I don't see them on the screen, but I think Eric and Josh should be here somewhere.
Chairman Baldwin, we've admitted Josh.
Okay.
Hi, Chairman, we're here.
Oh, there you are. And you did brush your hair. Congratulations.
Thank you. Yeah, put some makeup on too.
Yeah, well, we needed that. We're going to talk
Yeah.
about hospitals and medical costs and hospital costs and et cetera. This is a huge topic. We're going to squeeze this into the afternoon. And gentlemen, if you want to go ahead and do your presentation, we'll save questions until the end. And you've only got 25 people watching, so you need to make it entertaining so we can get back up to 40. Go
That's
ahead.
26 more than we thought we'd have. So
Go ahead, sir. The floor is yours.
great. Thank you, Mr. Chairman and Madam Chairman, committee members. I'm Eric Boley, President of the Wyoming Hospital Association. And Josh is running the camera here. So he'll be helping to co-present with me. And if there was ever a time to run away, right now is the time to do it. As the chairman said, this is a huge topic. We've tried to condense it down into what we hope will be some valuable information as we start working together. And for some of you, it'll obviously be redundant information, but for those that are new to the committee, we hope that it helps at least as we talk about healthcare issues going forward throughout the interim and over the next couple of years. It'll help understand what we're talking about. We've just included a page that talks about the mission of the Wyoming Hospital Association, but then we thought we'd just jump right into it. On the third page of the presentation, we've just listed out the hospitals that Wyoming has. We've also tried to identify for you the communities they're based in, their governance structure, and also their management affiliation or ownership. And then there's some important information to the right that talks about how many beds each of those facilities is licensed for, if they have some SNF beds. And then I don't know exactly how accurate it is. We've tried to keep it up to date, but it talks about how many employed staff members are in each of those facilities.
Hey,
And so as you can, yes.
hold on for 1 minute. On your slide presentation on the screen, you've got a block there. It's talking about live captions and subtitles. We can't see it. And maybe if you could maximize that and make that a little bigger for us.
Yep. Is that better?
Much better. Thank you.
Okay, great. Sorry about that. We'll get better as we go. So as you can see, we have 16 critical access hospitals. We're going to talk about what critical access hospitals are. Then we have our PPS hospitals. And then we have at the bottom of the list, we've got 3 other types of facilities listed. We have a surgical hospital. We have a Wyoming Behavioral Institute, which you've all heard a lot about today as we've talked about several different topics. And then we have a rehabilitation hospital. These are our current members. There's also one other hospital in the state. It's physician owned that isn't on the list here. This also does not list all of the VA facilities in the state, nor does it list the state facilities, but we just thought this might be good information for you to have so you can kind of see how we're set up around the state. Getting into the different types of hospitals, we have our critical access hospitals. So This is all under CMS rules and regulations, and we'll be talking a little bit more about rules and regulations as we move through this. But a critical access hospital has to have 25 beds or less, has to be located more than 35 miles from another hospital. There's some kind of weird intricacies in being able to keep that critical access designation, and we're going to talk to you about why that designation is important. But the average length of stay for inpatients has to be less than 96 hours. And it's a requirement that we provide 24-hour, 7-day-a-week emergency services. The benefits to a critical access hospital, which are different from the PPS hospitals, and we'll explain what that acronym means, but critical access hospitals are cost-based reimbursement. And so when these hospitals were set up 20 years ago, I think is about when they started, maybe even 30 years ago, it was done to help rural facilities and rural communities be able to provide care. And one of the major things we're going to talk about is the expense, especially with fixed costs of running a hospital, especially when you have low volume and you're serving a small population. And so critical access designation allowed these small hospitals to be reimbursed at a higher rate to cover their costs for their Medicare patients. And at one point, we actually received 101% of our allowable costs. But during the Obama administration, when the Affordable Care Act was passed, there were some trade-offs that were given to try and ensure that everyone had coverage. And so the 101% coverage went down to 99%. It was decreased by 2%. Included in that, you can see your capital improvement costs. And then it allows us to also access additional federal funds that are administered through the Office of Rural Health. And that's called the FLEX program. And there's money that comes in each year. We meet with the Office of Rural Health, and it's kind of self-directed. So all of our hospitals meet with the Office of Rural Health, and then they can determine how that money can be spent. And most of the time it's used for education of either staff or the board members. It's used for technical assistance. It was really important when electronic health records first came out. There was a huge expense to all the hospitals, but some of that money could be used for that. And then there's money that's set aside for grants that can be applied for over the year or the 2 years that the funding is there before they meet again and reallocate those funds. The second type of hospitals are prospective payment system hospitals, PPS hospitals. So our 9 largest hospitals in the state, those that are above 25 beds, are PPS hospitals. And it has a very different way that they are reimbursed for their services. And you can see, I don't need to read to you there, but it's more of a fee for service reimbursement. They do receive, at the end of the year, we're going to talk about this, they do, at the end of the year, there is an attempt to true up the actual cost of delivering care to Medicare patients. And so every hospital in the state has to file a cost report, but this is all basically a fee for service way of providing service. So a patient comes in, whatever services are provided is then billed to Medicare, and Medicare has a fee schedule that they reimburse us on, and that money is allocated back to the facility. And we're going to talk a little bit more about billing and all of that as we go through this. Chairman, you just want us to keep going, or do you want us to take questions as they come up?
No, let's let you work through. We'll save our questions till later in the presentation.
Okay, sounds good. So as you can see from the chart that we provided you, there are different types of hospitals. There are 2 types of governmental hospitals in our state. There's the county memorial hospital, and then there are hospital districts. We've given you the definition of what a county memorial hospital is there, but the difference really between a county memorial and a hospital district is the county memorial hospital is owned by the county. The county has the authority to levy taxes to help, if they decide to do that, to help sustain those hospitals. The board of directors are appointed by the county commissioners in each of those. And as you can see below, there are some things that county memorial hospitals are allowed to do. They can issue revenue bonds. A lot of times they'll do that when they need to do capital construction. They can use notes or warrants. Warrants are a way for us to get advancements on anticipated revenue that'll come through, normally through taxation. They have the ability to go out and get lines of credit. And so that's one differentiation that you'll see between a county memorial hospital and a hospital district. Hospital districts, they are established by the voters, and it's usually done. They're not always clearly defined within a specific county. We actually have some districts that straddle a county line, but they are done by a resolution, and it covers a geographical area. It has to go to the voters. I think with recent passage of some legislation, it has to be done now during the general election as opposed to at any time. The hospital district actually has the ability to levy taxes themselves. And for a hospital district, if they are voted in and are passed as a hospital district, they automatically can get up to 3 mills. And then they also have the ability to go back to the voters again and have it voted in to get up to an additional 3 mills. With that additional 3 mills, though, it has to go back to the voters. I think it's every 2 or 4 years to have that authorized by the voters. But that's one of the major differences. Also with the hospital district, the governing board is elected, and they normally serve 4-year terms. They can either be a 5-member or a 7-member board, depending on what they've decided in those communities. And they'll have alternating terms so that there's continuity, so that the entire board doesn't rotate off at any given time. If there's any you want to jump in here, make sure you do. Then the third type of hospitals that we have are private hospitals. We have 6 or 7 of those in our state. As you can see, a lot of those are investor owned, and any revenue that's generated normally goes to shareholders. We also have private hospitals that are nonprofits, and we have a handful of those in our state. Again, they receive tax exemption a lot of times for their services, those communities, but they're run by a nonprofit entity. And then, as we've already stated, we have 1 or 2 physician-owned hospitals where the physicians have actually gone out and built the hospital, and they own and operate that on their own. So I heard Representative Ottman ask a question earlier today. I think during the first couple of hours about a homeless person that went into the hospital and needed surgery, and how that would be reimbursed. And I think we kind of got into Medicaid. But the answer to her question is what would happen with that patient. In 1986, Congress passed what's called EMTALA, the Emergency Medical Treatment and Labor Act. And basically under this act, any person that presents at our hospital is guaranteed to receive stabilizing treatment. And so we are required to take any patient that walks through our emergency room doors and make sure that they're stable and safe. So part of the answer to Representative Ottman's question is, if that patient that ended up needing surgery, if it was a life-threatening condition and surgery was the only way to save that person's life, EMTALA would require us to go ahead and operate and take care of that patient and save their life, whether they have the ability to pay or not. The other thing to realize is no matter who walks through our doors at the emergency rooms, we never determine whether or not they have the ability to pay or not. At that time, our immediate concern is to stabilize and make sure that their lives are safe. And then after the fact, we start talking about whether they have insurance or if not, and we start talking to them about those different possibilities. There are actually, in every one of the emergency rooms, if you've ever been there, there are actually huge signs that are posted that say that we have to be there to serve, whether or not you have the ability to pay. And it's posted very, very clearly so that people don't feel threatened or that they won't be taken care of when they walk in. And then there one thing that I think would be important for you to understand, and we don't really have them here, but in some of our surrounding communities, our surrounding states, they have been standing up what are called freestanding emergency rooms. And luckily, in my opinion, those have not come into our state, but those freestanding emergency rooms really are not much more than an urgent care center. And they actually have to have an affiliate agreement with a hospital, a true hospital, in the event that they have a patient that's presented that could be in a life-threatening situation. And then they're transferred from that freestanding emergency room to a real hospital to take care of that patient. So this will really knock your socks off as we go through this one. I can see excitement on all your faces already. So hospital operations. The thing I'd like to say before we even get into this is healthcare and hospitals are probably one of the most regulated industries in the country. I think banks are probably right up there with us, and then maybe air traffic control. But the rules and regulations for healthcare is onerous, and the federal government is very heavy-handed. CMS, which is the Centers for Medicare and Medicaid Services, is basically the 1,000-pound gorilla, and everything that we do has to be done in compliance with their rules and regulations. In our hospitals, and depending on the size of the hospital and the scope of the services they provide, there are profitable services and there are non-profitable services. For the most part, most of the services that we render in our hospitals are non-profitable. There are only a few different types of services we provide that traditionally actually are profitable. And those are the ones that are used to help sustain and offset the losses that we see in our other services. Every 3 years under the CMS rules and regulations, especially for critical access hospitals, but for all of them, we're required to perform a community needs assessment where we bring stakeholders in from all different walks of life, and we figure out what is needed. And there are matrix and other data that we're able to use to determine some of the different variables in our different communities, but we bring stakeholders together and decide what the community needs, the greatest needs are. And then under CMS rules, we're required to put a program together to start to address those specific needs. And going back to some of your other conversations earlier today, I don't think you'd be surprised, but in most of our communities, mental and behavioral health is one of the areas we traditionally identify, as well as suicide, and then some other services. One of the other things that we also wanted to talk about is in most of our communities, the only healthcare available is in our hospitals, especially in our rural communities. And so there are a lot of great expectations from the citizens of those communities that the hospital should provide as many, if not all, services that are required under healthcare. And this is a big issue because, as we've already discussed, many of those are non-profitable, even in larger urban areas. But when you get into a small remote area, there are certain services that are needed or wanted, but are not sustainable. And so those elected boards and the administration of those hospitals have some really tough decisions to make. And we've listed just a few of the things that are kind of interesting, but EMS obviously is a huge issue. We do have some EMS services that are run by our hospitals around the state. We also have some self-standing or self-governed nonprofit EMS services, and then we have some private EMS services in our state. But EMS services is vital; it's crucial, but they're becoming harder and harder to keep open and to maintain staffing. Dialysis is another one we hear about. It's a very important life-saving function, but to set up a dialysis treatment center, to be able to staff it, to be able to meet the rules and regulations, and to have enough volume is very difficult. And so that's one that we hear about. Long-term care, again, you've heard a lot about that one today, but a lot of our community hospitals have taken on long-term care as part of their operation. Again, it's another one of those areas where if we break even, we're very lucky, but most of the times the long-term care operations are subsidized by what happens in the hospitals. Anesthesia is another one, which is, again, when we talk about stroke, heart attack, babies, having anesthesia services to manage airways to help people, very important, but also very expensive. And then PT, OT, and speech, the different types of therapies. It's good to have people stay home and receive those therapies as opposed to have to travel for them. But again, it's just one of many that we could talk about. Home health services is another that's not on the list, but it's one that a lot of our hospitals try to operate. But again, it's even more heavily regulated than the hospital alone. It's very difficult to provide those services. And so you can kind of see it's a balancing act, and it's a difficult one. But when we talk about hospitals' profitability, their ability to stay viable and sustainable, they're making decisions not even annually, but sometimes monthly or quarterly on what services they can continue to provide at a loss to continue to provide healthcare in their communities, but while they still try to maintain stability and stay in operations. Anything you want to? So we kind of talked about CMS, but we wanted to get into rules and regulations. We've listed just a few of the different things here. And I'm going to tell you right now, we're going to miss. We've spent a lot of time, Josh and I are on the road, went to Revenue Committee in Riverton and talked about it all the way over and all the way back. Talked about it last week, and we've tried to capture as much as we can, but I promise you we've missed a whole lot because this onion's got a lot of layers to it. But when it comes to rules and regulations, we operate under CMS rules and regulations. They're the 1,000-pound gorilla. They actually use our state agency, state license and survey to enforce their rules. And so our healthcare facilities are surveyed at regular intervals by the state licenses survey team. They normally will come in. Our critical access hospitals, I believe, have to be surveyed under statute or under CMS rules every 3 to 5 years. I think it's a little bit less frequent with our PPS hospitals, but then if a patient makes a complaint against any of our healthcare facilities, our Office of License Survey has to come in and investigate those as well. You'll probably realize that with COVID, there have been a lot of challenges. And so during COVID, we've actually seen a shift from some of the old traditional survey. They've been coming in to take a look at our infection control procedures and different things like that, both in our hospitals and our nursing homes. But for a hospital to become a critical access hospital, they have to go through, once they become a hospital, they have to apply to become a critical access hospital, meet all those requirements. And then there's an initial survey that's done to come in and let CMS know that that hospital's met the requirements. And then there are follow-up surveys that take place each year. A lot of our larger hospitals use Joint Commission. Joint Commission is a freestanding survey agency, but it's used to determine the quality that our hospitals are providing. And what's great here is if a hospital doesn't do Joint Commission, the larger ones, a lot of times they're kind of looked down upon. And so it's important for them to use Joint Commission to do those surveys, but it comes with a cost. They actually have to pay to be surveyed so they can post the results of that survey so that people and regulatory authorities feel comfortable with what they're doing. And then finally, this is kind of an interesting one, HCAP surveys. I don't know if any of you have had an inpatient stay recently, but HCAPS it's a survey mechanism that we were required to put in place that has us survey our patients and find out what their satisfaction was with their stay. And there's 25 or 30 questions that are asked. And again, we get to pay for the privilege of having outside agency call our patients and compile all that data and then resubmit it back to us. But the HCAP surveys actually go into the 5-star rating of our hospitals. And so CMS now has a rating scale, and they rate our hospitals from 5-star all the way down to 1-star based on the HCAP results and our state surveys and other things. But that's required again. And so, as I said, CMS kind of rules the roost, but And a lot of the stuff that we have to do is done at additional expense to hospitals that are already struggling, a lot of them with their bottom lines. Anything you want to say about?
So just as an example, perhaps on the HCAP survey that goes out, it's questions like, was the room you were staying in quiet, right? Did nurses respond to your questions? It's very much like Eric said, a patient satisfaction survey. I think the response rate on those varies, right? So people that had a great experience or a bad experience are probably quick to turn them in. Sometimes the surveys go out quite a bit after your stay as well too. So, but that's kind of what it looks like, just for a frame of reference.
If there's an interest, we could probably get you a copy of one of the questionnaires. I know Chairman Baldwin's familiar with those after working at the hospital in Cameron, but we could get you a list of kind of the most frequently asked questions if there's an interest. So going back to operations of hospitals, and this kind of gets into the cost of healthcare. In each of our facilities, we have fixed and we have variable costs. And so the fixed costs, it's not a very long list, but it's a very important list. Those fixed costs exist whether or not we see a patient. And so the building and property equipment necessary, and then salaries, which is a huge expense. Those are fixed costs that we have to do. As you saw with the slides, we have to provide emergency care 24/7. We don't know what's going to happen in our trauma hospitals. They got to be prepared to take care of any trauma that walks through. Our hospitals have to be prepared to deliver babies at any minute of the day or night. And so whether or not we have patients or not, we have high fixed costs. Buildings are expensive, property is expensive. More importantly, equipment is expensive. The best practices, most of our hospitals need to have a CT machine, millions and millions of dollars, an MRI machine, millions of dollars, radiology equipment, and others that we have to have so that we can provide the life-saving care that's necessary when people walk through the doors. On top of that, we've got a lot of variable costs, and you can kind of see a list of those. A lot of our lab supplies, our medications are variable because you never know exactly what you need. We have to have a certain amount on hand, but there are others that we don't have the exact volumes on. And then there are a lot of disposable supplies. The minute you walk through the door, I remember this really well, and we got a little bit better at it, but every supply used to have a sticker on it, and that sticker had a barcode, and then you get your sheet at the end of the day, and the nurses needed to put all of those stickers on there, and then that could go to the billing office and they could scan the barcode. But we stickered a lot of different items in our general supply area, and that's how we captured our charges. And I remember seeing nurses walking around, they kind of looked like Christmas trees. They had stickers all over their scrubs because they didn't have time to put them on. And we've gotten better with that. Now we're able to do a lot of that barcoding right at the bedside as opposed to have to transfer the stickers. But there's a ton of variable costs. And we're going to talk about the cost reports here in just a little bit. But a lot of the variable costs are captured, but there are a lot of unallowable costs that are not allowed under CMS rules and regulations when they talk about what our actual cost to deliver the care is. The other cost, obviously, is our physicians, which are ultimately one of the most important parts of any visit. About 40%, I believe, of the licensed providers in the state are now employed, is what I think I remember hearing not too long ago. So we've had a lot of our providers, our physicians, our PAs, our nurse practitioners, anesthesiologists, others that have decided that an employment contract is the way that they want to go, as opposed to being an independent contractor. And one of those reasons is malpractice. When they come in and they're part of an employed provider, they don't have to go out and get their own malpractice insurance. They actually get to share the malpractice that the facilities have. But on top of that, and in just a minute, we're going to kind of talk about the billing process. On top of that, the employer actually provides a lot of the back office staff that's really necessary for them to be able to sustain their livelihood and their incomes. one of the benefits, though, to being an independent contractor is just that you can perform your duties independently. You just have a contract in place to provide services, but you do your own billing and collections. You kind of set your own schedule, and you have the ability to move around and set up contracts with other facilities if that's what you want to do.
I think, Mr. Chairman, the only thing I would add, and for people to keep in mind as well, is say, particularly in a small community, say the hospital wants to recruit a cardiac doctor, and Chairman Baldwin, you'd certainly be familiar with this, but you really don't recruit one doctor. Otherwise, that doctor is on call 24 hours a day, 7 days a week. Really, for physician satisfaction and prevent burnout, you really need more than one. So the expense of 2 physicians obviously is more, but I think something that's important to keep in mind when you're talking about service lines available in certain communities and the ability to recruit is those physicians' willingness and how much call they're willing to take on.
Well, I think one other thing that I'd just like to cover under fixed costs, and we talked about it, missed the list, but all of you heard a lot about it during our last session as we talked about the health information exchange. But one of the big fixed costs that have come in over the last 10 or 12 years is the electronic health record that each hospital has been required under federal law to implement. And I know there's a lot of people that feel good about it and some that don't like it very much, but either way, we were forced to do that. CMS required it, or else they cut our reimbursement each year up to 10% of our Medicare reimbursement. They did offer us an incentive, though. If we met different levels or phases of implementation, there were rewards, and we received cash to help pay for those expenditures for the electronic health record. The interesting thing, though, is about at the end of the 4 years, which is how long it was supposed to take to get electronic health records implemented, most of the EHR companies decided that they needed to change their operating platform. And so it ended up costing us almost the amount of money we got from the federal government to pay for the first EHR. And so there are ongoing expenses with the EHR. Our physician clinics have also implemented those. And again, they were under the same rules. They lost reimbursement. Some of them just decided it was better to just get a cut in reimbursement than jump in the middle of the electronic health records. But hospitals had to do that. And that's another huge fixed cost that I just wanted to identify before we moved on. So during the interim, during the general session, we got to talking a little bit about billing and collections of hospitals. And I'm not going to get way into the weeds on this, but from back in my days of running and operating a hospital, this was one of the most important parts for this, because cash flow is the lifeblood of a hospital. And so we kind of wanted to just describe the billing and collection process on a real high level. So it's really easy to see the patient is seen. When the patient is discharged, the physician will dictate, and it used to be that they dictate into a tape recorder, and then that would go to medical records, and we had someone there that would type out the dictation and enter it into a paper chart. Now a lot of this is done electronically, but the physician still dictates using voice recognition software. And then that medical record still goes to medical records, where we have coders, and these coders have been trained over the years, which is really difficult. We don't even have a coding class here in Wyoming, so we have to hire people that are experts in coding, and they will go in and they'll take a look at the medical record, and they'll determine what should be billed. We're going to talk a little bit about that in a minute. What should be billed? That bill is then electronically sent to the payer, whether it's Medicaid, Medicare, or one of the commercial insurances. But again, we get to pay to have that go to a clearinghouse, and that clearinghouse then submits it to the payer, and that claim goes through a scrubber to make sure that the coding is accurate as possible, to make sure there's no fraud or abuse. And so it's submitted through that clearinghouse, goes through the scrubber, gets to the payer. Then we get to wait. Usually it's about 45 days. sometimes longer. We'll get a payment along with an explanation of benefits and EOB coming back showing what they're going to pay, and then it shows what the patient portion is due. And then the patient at that point is billed for whatever is their responsibility, whether it's their copay or out-of-pocket maximums. And at that point, we go to the collection process. So the patient's billed, we wait for the payment. In most cases, we wait up to 90 days and try to collect by sending statements on a monthly basis. At around 90-day mark, and give or take, depending on the facility, we use a pre-collection letter to let them know, hey, if you don't pay or if you don't come in and make arrangements with us, we're going to have to send you to collection. Normally, those are sent a couple of times. So we're now 4 months out before, a lot of times, before money's collected. Then and for that pre-collection letter, we usually get to pay the collection agency to send it out just so that it carries a little more weight. Then it goes to the collection agency and they'll send a couple of notices before they actually start the collection process. Once the claim is turned over to the collection agency, the hospital, whether it's for physician fees or for the hospital fees, they're going to take a percentage, and usually it's a pretty good chunk of whatever is collected. And then at that point, it kind of becomes the collection agency's job to collect whatever they can from the payers. We've listed below, and these are pretty common in every one of our hospitals, options for patients. Most of our hospitals, if not all, offer some form of a payment plan. And a lot of times, our patients could be more proactive, but a lot of times they're not. And so we actually have people on our staff that will go and talk to these folks, set up appointments to talk to them about the different options that they have available. Most of our payment plans are done without interest. Thousands of dollars are extended over several years, and monthly payments are expected at no interest. But once those payments start to fall in arrears, then we have to figure out another way to go. One of our hospitals just implemented something really, what I thought was really creative. They partnered with their local bank and they're offering a debit card, and so or a credit card to pay it, and then the bank is actually working on the collection side of things. But it seems to be a really good program. If a patient is uninsured, again, they can come in and they can meet with our financial people. And based off of the federal poverty guidelines, there's a sliding fee schedule. And so if a patient comes in and actually works with our folks, and they're uninsured, unemployed, depending on what it is, based on their income levels, and we have to go through a series of paperwork with them, we can write off a portion or all of their bill, depending on where they fall in that federal poverty guidelines fee schedule or fee scale. And then that's where charity care comes in, and the bad debt that we talk about. And you've heard us talk about these numbers repeatedly, and again, we're going to talk about cost reports, but the cost of delivering care, uncompensated care, which is bad debt and charity care, in our state, it costs our hospitals between $100 and $120 million annually. That's just the cost of delivering that care. It has nothing to do with their charges. It's the actual cost, and it's not even a true cost. We're going to talk a little bit about that.
And perhaps not at every hospital, but at least some hospitals, you can be insured and still fall onto the sliding fee scale for the portion that's left over. So you don't necessarily have to be uninsured to take advantage of those.
And I think a good example is with those that are receiving subsidies and are on the exchange, have huge co-payments and out-of-pocket maximums that are really staggering. It gives them an option to help with that portion of their bills. All right, so we're halfway through, and I'm gonna try and lighten this thing up a little bit. We're gonna talk about coding, and again, we've already talked about the fact that we need specialists to help do the coding. And no offense to Senator Baldwin, but our providers sometimes make it really difficult for us to code properly. And so we're going to talk about different types of coding, and we're going to do a David Letterman top 10 here in just a minute. So 20 years ago, I guess it was, CMS changed the way that they did their billing, and they went to a DRG, which is a diagnostic related group. You can see that there. It kind of gives you a definition, but that diagnostic related group has to do with inpatient stays, and it is determined, and it's a whole diagnosis that is determined by the CPT and the ICD-10 codes. And so a physician or a provider has to dictate very accurately in their medical records why the patient was seen, has to identify right, left, top, bottom, back, forth, whatever you want to. They've got to be very specific in what they have treated. And there is an ICD-10 code that is equated to that stay. There are also CPT codes that are coded based on what the dictation says. And then based on the ICD-10 and the CPT codes, those are used to determine which of the DRG codes is used to bill our insurers, our Medicare. So ICD-10s used to be ICD-9s. And it was probably 6-8 years ago, I think. ICD-9s were converted to ICD-10s. I think it was during President Obama's administration. And we went from somewhere around 12,000 codes to in 2021, there are 72,000 plus codes that have to be looked at under ICD-10. So this is where our David Letterman top 10 comes in. So these ICD-10 codes really drill down. And so I thought we'd do the 10 greatest ICD-10 codes. And these are true. Number 10, struck by an orca. Number 9, bitten by a pig. Number 8 is struck by a duck. Number 7 is problems in relationships with your in-laws. The doctors are supposed to diagnose this, and this is part of their transcription. Number 6, walked into a lamppost, and I'm pretty sure I've seen Senator Baldwin do that one. Number 5, burned due to water skis on fire. Number 4, other contact with cow, and that comes after bitten by cow or kicked by a cow. Number 3 is a injury to a space occupant of a spacecraft collision. I can't even say it. Number 2 is struck by a macaw. And this one's a good one, and we can all think about who this would pertain to. Number 1, bizarre personal appearance. So that's just a small taste of the 72,000 different codes that our providers have to try and figure out how to bill. So once again, we go back to needing specialists to do this coding. And if it's not done accurately, if it's not done properly, it could cost thousands of dollars to each of our facilities. But this is how we bill for every single patient encounter that comes in. In the clinic, when you see a provider, and also when they're doing their own billing, they actually use the HCPCS codes, which is the HCPCS. Those are coding systems for the care, the provider of that care. So there's a different coding for the actual providers. These others have to do with the procedures that take place when the patient's seen. All right, I'm gonna let Josh talk for a minute because I'm losing my voice, and he likes this stuff.
Sure. So Mr. Chairman, members of the committee, we'll move into alternative payment models. And I think this is probably something all of you have at least heard a little bit about, right? So the history of healthcare, at least for the last several decades, has been fee for service, right? So patient comes into a healthcare setting, the doctor performs some kind of service, and they get paid based on those different services. And alternative payment models are typically aimed at providing more of a value-based, or taking a value-based approach, or creating one payment, one amount for some type of encounter. So like in bundled payments, for example, like a knee replacement is a common bundle done around the country where there's been a price that's been determined for a number of services that go into a knee replacement, including some of your aftercare, and all the providers and facilities included in that bundle share that payment, right? And so the idea is for them to be able to create some efficiencies and drive down costs. Now, some of the issues with bundles that you'll run into in a rural setting is that volume is critical. So it's critical. Well, it's critical for two important reasons. One is you need enough experience in that particular procedure to know how to price it correctly. And then number two is that if you don't have enough volume and you have a case that goes wrong, so let's say like in a knee replacement, somebody comes out of the hospital after knee replacement, and inside 30 days they fall and tear apart what was done to them, and they're back in an inpatient setting, which is of course very expensive. So if you don't have enough volume to cover for that one case that was quite expensive and went wrong, is you're not going to be able to cover your cost. You're going to have a loss on that procedure over the course of a period of time. But there has been some evidence that those type of payments arrangements can be successful. It also requires a coordination of a number of players. So sticking with the knee replacement example, is that if the hospital employs the surgeons, employs the physical therapists, and they have control over all the players, it becomes a little bit easier. Now, if you don't employ the physicians, if the physical therapy, for example, is somewhere outside of your system, you have to have contracts with all of those different entities and payment arrangements with them that need to be negotiated and figured out. Medicare shared savings, just to move along, is this is an oversimplification, but basically Medicare says they'll pay X for a certain procedure or types of procedures, and then whatever money that you can save them in that program, they'll share back with the facility or the provider. Accountable care organizations are, again, an oversimplification, but really a collaborative of different providers, sometimes multiple hospitals and specialty clinics and things like that. And then patient-centered medical homes, which is something Wyoming's invested heavily in over the last probably 15 years, are their primary care practices that have agreed to restructure the way they deliver care in exchange for a different payment type. So it's, as the name suggests, it's very patient-centered. It's about providing the type of care in the right place at the right time for patients based on their needs. Again, some evidence of success with that in terms of people being able to access care. It also includes practitioners working at the top of their license, right? So an RN isn't going to do something a CNA would do, for example, and that they're going to work at the top of their license and be spending their time doing the things that they were trained to. This continues to be a big part of the conversation. All of these ideas are a big part of the conversation in healthcare cost and finance and just healthcare reform. I think right now, if you look across the country, these types of payment models really represent only a small fraction of the market. The world, as we know it, still continues to run fee for service. But that being said, we've asked the state employees group to look at if there's any potential for bundle payments. Our member hospitals have said that they'd be willing to work with the state employees plan if there's an opportunity where we can come together on something like that. Our members and us at the WHA are committed to exploring these opportunities. And if there's an opportunity to keep our hospitals financially strong and then deliver the best care to patients and help lower costs, we're here to be a part of that. We continue to participate on the governor's healthcare task force and have a role in those conversations and offer ideas there as well. So.
One other thing that's not listed here, but kind of goes along, is also direct contracting. So it gives the insurer a chance to directly contract with one provider. So it drives volume, which is important, I think, to helping lower the costs for care. We do have a few of those in place around the state. But one of the pitfalls to some of these federal programs is they're not designed for rural Wyoming. They're not designed for rural USA, honestly. They require large populations of Medicare covered lives. And it's really difficult for us with our state spread out and with the demographics for us to actually qualify for, especially for the accountable care organizations and others. We've looked at all kinds of different models in an attempt to move more towards quality. But the programs that keep getting designed out there, they almost immediately rule us out because we just can't meet a lot of those requirements to be able to participate.
Yes, I would add one more example that was in Laramie County until recently was the PACE program. So the program of all-inclusive care for the elderly. And the way that worked was they were paid a per member per month capitated rate. The program was fully capitated. And then the program PACE was responsible for all of the care, right? So it was primary care, medications, vision, dental, physical therapy, everything they needed. And then if the patient went into a nursing home, they were responsible for that cost as well.
And at a later date, we can talk about how we think that's turned out, but we won't get into that because we're trying to be good today.
So next slide, uncompensated care. So this is something this committee has certainly heard us talk about quite a lot. But this is exactly what it sounds like. This is care that hospitals provide for which no payment is received. And every time we talk about this number again, and we want to be very, very clear on this, that the numbers that we quote are based on our cost, the actual cost to delivering that care. It's not charges. And there's a big difference there. And so we just want to be very clear that this is actual cost to us. So it's about $120 million per year, give or take, year over year in this state that our hospitals are providing. Now this includes, uncompensated care includes a number of things. So bad debt, for example. So bad debt is really unpaid bills. So bad debt is not the gap between what Medicaid paid and the cost of your care, right? That is figured into uncompensated care, but bad debt is actually a bill that you thought you were going to get paid on. And after a period of time, it becomes clear that you're not, and you eventually move it into bad debt. So, or you categorize it as such. What most hospitals try to do early on, particularly in inpatient stays, is that if they identify that a patient is uninsured or underinsured, that they're working with them, number one, to identify a pay source for them. And if they can't do that, whether it's Medicaid, Medicare, Social Security, some other means tested program, if that's not possible, what they want to do is have them fill out the applications for charity care or financial assistance. And then that's where you're on the sliding fee scale, you can work out payment plans, you can do a number of things. And so that is certainly the preference for hospitals rather than expecting payment for something and not being able to collect. And then I kind of lay out a description of financial assistance underneath there. And then in the red down there, it's the actual formula that's used to determine your uncompensated care. So, your bad debt plus financial assistance, and you can see what it looks like there. But really the take home message is that across our hospitals in this state, roughly $120 million of that care is provided, and there's no reimbursement for that. This is where you're going to see hospitals that, particularly in rural areas, not just in Wyoming, but across the country, will have negative margins in certain years, or they'll have very thin margins. And so what that really means is, if you're breaking even, that means you're not investing in your facilities, you're not recruiting providers. If an air handler, for example, goes out on your building, I mean, those are, I think one is $500,000, right? To keep clean air moving through your facility. These are critical pieces of infrastructure. And if you're not making money, or you're breaking even or worse, these are things that can cause your physical plant to fail. It's a big deal. It's something that we're certainly concerned about here, as well as our hospital leaders throughout the state.
We're actually going to talk a little bit when we get to cost reports. We'll spend just a couple minutes talking about why the cost to charge ratio is important and where it comes from. One other item that should be mentioned here is 2 or 3 years ago, I think it was, CMS came out with new rules and regulations that had to do with readmissions of patients. And this has been a contributing factor to some of this bad debt, bad debt, uncompensated care. When a patient comes in and is seen in our hospital and then they're discharged, if they're readmitted, for any reason to the hospital within 30 days, then the hospital is totally on the hook for all of that care that's provided for that stay. We have no control, and you guys have talked a lot about social determinants of health. You talked about wraparound services. We have no control whether that patient's going to go home and be compliant with the orders that are given. If they come in for one diagnosis and they end up presenting back because of something totally unrelated and different, we're still on the hook for that. And so that's another issue that continues to drive up the uncompensated care, but also that puts our hospitals at risk financially for providing really expensive services where there's no chance of reimbursement.
So kind of staying along those lines, but a little bit different. So community benefit is, there were parts of the Affordable Care Act that allow the IRS to make certain requirements of nonprofit community hospitals. They also apply to governmental hospitals. So like we talked about, hospital districts and county memorial hospitals. And there was really three parts of that community benefit. So one was that hospitals either had to lead or be meaningfully involved in the development of community health needs assessment. They had to either lead or be meaningfully involved in the creation of a community health improvement plan. So looking at the community's needs and helping create a plan that addresses those needs. And then three was they had to direct their community benefit spending in a way that aligned with that health improvement plan that was created. So some of these things in here, so we report to the IRS, nonprofit hospitals report to the IRS community benefit, and these categories you see on the page are those sort of broader areas, right? So financial assistance, like we talked about before, bad debt's not a part of that. So this is one of the reasons you want to get somebody early on financial assistance and provide help to them so they can pay whatever portion they're able. The gap in Medicaid and other means tested programs is counted here. Community health improvement services, and there's more than this. This is not an exhaustive list, but these are some examples of health improvement services. So transportation, information referral, community-based clinical services where there's no patient. So the examples there would be, free health screenings, for example. Health professions education, subsidized health services. So this is services that your hospital provides at a significant financial loss, but your organization has decided that your community, it's so important to this community that they have to provide it. Research and then cash and kind contributions for community benefit. Some hospitals do this via grant programs to social service organizations in their communities. It can be other in-kind donations. So say there's a faith nursing program and you give them a conference room in your building in order to have their meetings. And as long as those are open to the public and you're not charging anything for that, you can count it as community benefit. And so I say all that to say that hospitals, in addition to the care that they provide, which is uncompensated, there's a fair amount that every hospital is doing in their community. Again, millions of dollars worth across the state, investing in communities, whether it's providing free health services or supporting other community organizations. That they're a major player in reaching outside the walls and into their communities to improve health.
And before I stole Josh away from CRMC a couple of years ago, Josh actually traveled the state and helped each of the hospitals and communities put together these needs assessments. So he's very familiar with it. Our hospitals have to file a Schedule H, and most of them do Form 990s, and that helps those are required for them to keep their tax exempt status and to meet the requirements of the federal government when it comes to these community benefits. You want to keep going?
Sure.
All right.
So we'll talk a little bit about different kinds of payers, as the slide indicates. So Wyoming Medicaid, you all have obviously heard a lot about this. I think one thing to be clear about, and I think Stefan and Franz were very clear this morning about this, is that just being low income doesn't qualify you for Medicaid. There's categorical eligibility requirements that have to be met. And those are listed up there. Now, of course, if Medicaid is expanded, that includes a different group of people, and that would be based on your income from 100 to 138% of federal poverty. And as they've told you repeatedly, that's probably about 24,000 people in the state. The other one everybody knows about is Medicare. So again, people who are 65 or older, certain people with disabilities or end-stage renal disease qualify. There's also parts A through D that you can see what those cover over there. Some are for medications and other things, inpatient hospital visits, clinic visits, and so on. Both of these programs typically, as I'm sure you've all heard, reimburse at a rate lower than cost. And we're going to talk about Medicare cost reports and some of the things that go in there and what Medicare calls allowable costs. But what we would argue is that those allowable costs are do not encompass all of the costs that go into providing care. And then the next one is obviously commercial insurance that people are familiar with. About 50% of the people in Wyoming who are insured, commercially insured, get it through their employer. Some of those plans, so if they're self-funded plans, they're not regulated by the State Department of Insurance. Those are regulated by the U.S. Department of Labor. And then this is as of, I think March, this number down here, 24,574 Wyoming residents are signed up for individual plans on the marketplace or on the exchange. So we have 2 providers on the exchange this year for the first time since WinHealth went out of business several years ago. But there are 2 on there. One thing to note about the number about the people that get their insurance through the marketplace is that in most years, give or take, I think it's between like 92 and 97% of them are receiving subsidies from the federal government so that they can purchase plans. The remainder of them who are purchasing individual plans are paying the full freight. Again, important to know that people who sign up on the exchange, they're not part of a large or small group. They are purchasing individual plans. I think the average cost of those, if I remember right, for this year is something like the full freight, the unsubsidized amount is something like $650. I can double check that, but I believe that's the average price. Again, like as you've heard, I'm sure, these type of plans typically reimburse providers and hospitals at a greater rate than Medicare and Medicaid. I added this slide in here just to sort of level set some terms so that we're speaking a common language. It talks about cost and then charge or price and reimbursement. And when we have conversations, and even in the governor's healthcare task force, when we're talking about cost, we try to be very clear with one another about whose cost, right? Is it the cost to me as an insured person and what I pay for premiums out of pocket? Is it to the provider's cost for delivering care? Is it to, are we thinking more globally in terms of a system of healthcare in Wyoming and what it costs to have that? Is it cost to the Medicaid program, for example? So it matters when you're having these conversations to be clear about who you're referring to and whose cost and what that means to the overall picture. Also wanted to just add a quick definition of payer mix over to the side. You'll probably hear us talk about that quite a bit. It might be obvious what that is, but it's basically the ratio of the different payers in your system. So whether that's a commercial payer, a public payer, self-pay patients, and it's going to vary by community. So very generally speaking, rural areas tend to have more Medicaid, Medicare patients in their mix than say more urban areas. Again, it's unique to your location, but generally speaking, that it can look that way.
And obviously, the higher your payer mix is with commercial insurances or self-insured plans, probably the better off your bottom line is because you're receiving higher reimbursement. Just as kind of a point of fact, and these are just averages, but the payer mix in our state kind of looks something like this: about 10% or a little bit less would be Medicaid, 30 to 40%, depending on the market, obviously, is Medicare, and then around 50% would be commercial, and that includes TriStar and your different commercials, your self-insured plans, and then whatever's left over is normally attributable to bad debt or uncompensated care. But one thing also we want to make you aware of, under an executive order, right towards the end of his presidency, President Trump signed an executive order about transparency. As we talk about reimbursement and the consumer, there's been a lot of talk about shopping services, about the consumer taking some responsibility and ownership. So under that executive order, the most common DRGs, the most common codes are listed on all of our websites with what the charges are. And then one of the things to realize is no matter what we charge, that's never what we get. With our contracts we have in place with our insurance companies, there's a contractual allowance that's negotiated. So they take a percentage off of those billed charges. That information is also included by payer type on our websites. And then we also have calculators that are out there so a person can plug in. Not all of our hospitals have the ability to do this calculator, but they have the ability to plug in what their insurance is, what their deductibles and co-insurances are, and it'll actually tell them what their out-of-pocket amount would be. And so we've actually had on our website for over 10 years called Price Point. It was our attempt to provide this information, but it's been readily available, and it compares every hospital in the state with those common charges to allow consumers, patients to shop their services they want. But under this executive order, there's even more information out there. So you can actually see what our contractual allowances are with each of our insurance companies and have a better idea of what we're actually getting reimbursed for each of those. The other thing we mentioned, I'm not sure we got in front of both committees. I think it might have just been the House committee during the session as we talked about collection processes. But under CMS rules and regulations, we are required to charge the same amount to every patient that comes in. What we collect after the fact has to do with their ability to pay and who the payer is. But there's no discrimination. We actually have to charge the same amount, and no matter who the payer, what the payer source is. And then we've already talked about how the collection process works. I'll jump in the middle of this one because this is really exciting. You're going to love it. Ask Chairman Wilson. She got to spend 2 or 3 hours with us a year or two ago learning about cost reporting. And by the time it was over, we both were bleary-eyed. But in my former life, I was the chief financial officer of a hospital, and cost reporting was something that was required for all our hospitals to do every single year. And this is basically what we talked about. This is where a full year's worth of data is analyzed, and we are required by CMS to file this cost report. And this is where the truing up comes in. If we've been overpaid by Medicare, then as this cost report is filed, we have to submit money back to Medicare, back to the federal government. If they've underpaid us, then we receive a cost report settlement check. But these are not simple forms to fill out. It takes hours and hours. Most of the time especially in our small facilities, we have to hire specialists to come in and do these. I sat through a 3-day class one time thinking I might be able to do it. And I walked out of there and knew that I would never be able to do it. But they go through and take a look at all of our costs, all of our expenses, and go through a large formula and then come up with what they categorize as allowable costs. And those are used to determine whether or not we've been under or overpaid. Allowable costs are a misnomer, or they're not reality. There are certain expenses that absolutely are incurred in each of our hospitals, but Medicare, for whatever reasons, determined that they cannot be allowed as part of this cost report settlement. And so administrative fees to run a hospital, those are excluded from that. Physician fees, I believe, in the emergency room are excluded from that. There are other fees that cost the hospital money and are an expense, but aren't calculated into the cost. So we come up with what they determine as an allowable cost. And then they take a look at what the payments have been on an inpatient and an outpatient setting. And then, like I said, there's a truing up that takes place. This is used to help the critical access hospitals make sure that they've received 99% of their costs, their allowable costs. Also included in this, which has proven to be pretty important information over the past several years, is they do a calculation, and it's calculated for each one what the actual cost to the charges that each hospital has. We come up with a cost to charge ratio. And so it actually helps us kind of determine our efficiencies and allows us to determine, it's a good benchmark to allow us to understand where we sit as far as what our actual costs are compared to what we're charging, and allows us to make adjustments. We can spend a lot of time on this. There are specialists that I'm happy to provide, but I don't think you want to go too deep into this after this long day. But we offer to bring those if there's ever a time that you're interested in that.
Mr. Chairman, that's our presentation. That's what we have today, but certainly happy to answer questions.
I suspect there's questions out there. Thank you, gentlemen. And you left out my favorite on the top 10 list, and that's intentional harm done by paintball guns, ICD-10 code. That's my number one. And there's many, 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 many more. And we could go on about electronic medical records and ICD-10. That's a whole week of subject all by itself. Dear and not fond in my heart. Committee members, any questions? Put up a yellow hand. I see Representative Flintner. Go ahead, ma'am. You're muted, Representative.
Thank you, Mr. Chairman, and thank you, both of you guys, Eric and Josh, for your presentation. Were hospitals ever profitable? And when you speak to the coding, is that a federal requirement, and can anything be done to help in that arena? And then also in talking about critical access hospitals, as you know, where I live, we have them 35 plus miles apart. There's a lot of duplication of services. Is there ever, can that be changed? I mean, do we need to have a CT scanner in both Grable and in Level and in Powell and in Cody? And so if you could just speak to that in terms of fixed costs and how we can try to bring those down. Thank you.
Chairman Baldwin, Representative Flintner, they're really good questions. We'll do our best here. As far as profitability is concerned, I've been in the state for 26 years. I would say that it's becoming harder and harder to become profitable because of rules and regulations, changes in reimbursement. Hospitals were profitable. And in some states, they are very profitable. A lot of it has to do with economies of scale. A lot of it has to do with payer mixes. I know this isn't a hearing about Medicaid expansion, but in some of the states that have expanded Medicaid, north of us, south of us, hospitals are doing much better because they're eliminating a lot of their uncompensated care, up to 30% of that. So if you take a look at our figures, that would be $30 million basically that would come back into the system. But it is getting much more difficult. And I would tell you, you're identifying the critical access hospitals in our small rural communities really, really hard. And we're seeing two things happen. We're seeing tax revenue shrink in most of those communities. We're seeing population densities shrink. And we're getting an older population, which costs the system a whole lot more money. And so I always have heartburn, but I'm getting more and more heartburn about the ability for our hospitals to stay viable. There are some alternative payment ideas that are floating around back in DC. Senator Barrasso is actually spearheading some of it. And there have been attempts to take a look at whether a real hospital is actually needed in small communities or whether it could be an emergency room only, and change the reimbursement model. I think we're not to that point because I think there are too many other services that need to be offered in our small communities. But your question about the fixed costs and Bighorn Basin is kind of different than most of the rest of the state in the way that you have a pretty large group of critical access hospitals in a small geographical area. I think the problem that you have there, and you guys all saw this a couple of years ago when they were talking about the state facilities and the thought of doing something with some of the really, other than the state hospital and life resource center, those communities went ballistic and there was no chance that we could even privatize them. So you've got different management contracts in place in most of your facilities up there, different affiliations. I do think that there are ways that we could create economies of scale and we could eliminate duplicative services, but it would really take a strong concerted effort. And I think in your area, it's very, very different than, you know, most of the rest of the state where they're scattered much more broadly, 90 miles, 100 miles between them. So, and then as far as coding's concerned, I wish, I mean, I about had a conniption fit when ICD-10s came out. I was still at the hospital in Kemmerer, but it seems like unless we change, and I think there's a push by the federal government to change the way we're reimbursed and go to more of a quality, you know, and Josh talked about the alternative payment models, but until we move away from fee for service, all I can see is more ratcheting down from the coding side to make sure that they make it as difficult as possible to receive reimbursement. And I don't know if there's much more we can do until the system really changes. And to be honest with you, this is a lot of the issues we're talking about now, and we'll continue to talk about. For my 26 years in the state, we're still talking about the same things we were 25, 26 years ago. I just think that profitability and sustainability for some of our hospitals is getting more and more difficult. I hope that answers your question.
Senator Murphy, good to see you, sir. Go ahead with your question.
Thank you, Mr. Chairman. Let me ask your thoughts about particularly the hospitals on the borders of our state and the competition they receive from the big hospitals out of state, as well as your thoughts on recruiting physicians to our state seems to continue to be a problem. So I appreciate your comments.
All right, so you can jump in here. So let's talk about recruitment first, then we'll come back to what I call cannibalization. So recruitment is very, very difficult, and I think it's going to get more difficult. We've done away with all the programs to help with loan repayment, getting providers to relocate to Wyoming. It's costing us more and more money. We're having to offer more than even surrounding areas to be competitive. We have to offer a premium. There are signing bonuses, there are moving expenses that are incurred. And on top of that, we have to really recruit the spouse in a lot of cases, as opposed to the doctor. And with what's happening with our economy and some of the things that are happening in many of our communities, it's not as attractive as it used to be. And so I actually think we're hitting a really critical point right now. And the fact that we continued to cut reimbursement rates, so our Medicaid rates were cut again, and a 2.5% cut to the general fund is actually a 5% cut because we lose the federal match. But we've been cut now 2 or 3 times in the last 3 years, and so our rates are continuing to decline, which is less enticing to providers to come in and at least provide care to Medicaid, which 99% of our providers are doing. And I will tell you, we had this conversation Tuesday when we talked about Medicaid expansion, and we were talking with the WWAMI students last night. I had dinner with all the WWAMI students, first-year WWAMI students. And one of their big priorities and one of their big concerns is the fact that we have expanded Medicaid. And we have providers that actually have gone through the WWAMI program and either finished their 3-year obligation or can go to other states that are in the WWAMI program, but have expanded Medicaid. And we've had physicians here in our community that left Cheyenne to go to an expansion state. So I think our ability to recruit's only going to get harder. As far as our border towns, which is pretty much our whole state except for Casper and Lander and Riverton. This has been a big problem, but I believe it's becoming a bigger problem where we are seeing a large outmigration of services. And we've taken a look at some of the data just from the state employees alone, but it's pretty staggering to see how much of the care is leaving the state. I think some of the affiliate agreements that our folks have done here in Cheyenne, there in Laramie, over on the west side of the state with some of the bigger systems from surrounding states, it's actually paying dividends. And in most cases, a lot of it has to do with how those agreements are structured and whether or not their affiliate agreement is actually bringing services into the existing community or whether we're using that to feed the facilities out of state. But there's a huge concern. And as we talk about lowering cost, we really need to build economies of scale. So our fixed costs are our fixed costs. But if we see more patients, that fixed cost can be spread over more, which in turn would lower the overall cost to each individual patient. And that's something that we really want to do. That's why we're so interested in these alternative payment models where we could do bundled payments for knees and hips, or where we could do direct contracting with school districts or whatever it might be, so that we can drive more volume to specific providers. And in turn, we hope that it would lower that cost. I hope that answers your question. You have other thoughts?
Very good.
Maybe just, Mr. Chairman, just to reiterate again on recruitment, and some of these areas, particularly if you're adding a new service line, it's not just recruiting one provider, it's recruiting a couple. I don't think you can really understate that is a significant cost, particularly if you don't have the volume, but you feel committed to delivering that service line. It adds cost and it's significant.
Thank you, Josh. Representative Conley, go ahead.
Thanks, Mr. Chairman, and thanks, Eric and Josh, for another really great presentation. First, I appreciate your candor regarding Medicaid expansion and how it will help our hospitals, as well as recruitment and retention of physicians. We have to deal with that. But I'm going to ask a different question and wonder if there's anything that we can do that would address kind of needs that I see that go together that we haven't heard about. We heard, and you've mentioned aging, and you've mentioned some of the programs that are associated with aging. We heard at the interim committee discussion the importance of addressing aging. And I know that some hospitals in the state have retirement homes that are connected. Others have rehab facilities. So both rehab, addressing aging, they go together, as well as hospitals. Is there anything that we can do policy-wise that helps facilitate perhaps some of those efficiencies, either in terms of space or rules or policies, anything along those lines?
Chairman Baldwin, Representative Conley, that's another important question that we've been trying to figure out. One of the big problems that we run into when we talk about creating efficiencies and utilizing space wisely, again, it goes back to CMS. I've got a few ideas that are floating around, especially with the ARPA funding, where it's supposed to be used for infrastructure, where I think if we invest a little bit of ARPA funding into some of these facilities, we might be able to create those efficiencies, and it wouldn't cost the facilities money, but it would build infrastructure to allow them to be more efficient. As you know, we represent 2/3 of the nursing homes in the state as well. So, and that's my background too. But under CMS rules and regulations, most facilities can only carry one license. So they either have to be long-term care, they can't be assisted living, they can't be adult daycare because of those rules and regulations. But there are ways we can modify our buildings to have separate entrances or to have separate dining areas. There are things we could do, and I truly believe it could be categorized as an infrastructure, but then you have unused beds because you don't have enough residents, say for long-term care, but you could create the opportunity to do adult daycare, which is a service that's not provided in most of our communities, but was allow people stay at home longer and stay out of the most expensive setting, which is long-term care. You could also convert and have assisted living in part of the building. But again, as we've seen the cuts to Medicaid, which is 70% of the long-term care facilities revenue, they don't have money to reinvest. And so I do think there are ways to do it, but we've always got to walk the tightrope of what CMS will allow us to do. But I do think there are some creative ideas. I think there are 10 hospitals that have long-term care facilities that are attached or affiliated with them. And then one thing we didn't touch on, but there are 2 critical access hospitals that are kind of in the works right now. Ground's been broken in Saratoga to build a new critical access hospital. And there's a freestanding nursing home down there. It'd be nice to see some way for them to combine and work together so that they could share dietary services, laundry and housekeeping and back office stuff. Pinedale's another one where we hope that the sublet center and the new critical access hospital can combine and they can create some efficiencies. But we're going to have to get really creative and find ways to get around it. I also think there might be some waivers that we could use with Medicare to try and stand up some programs. If we can just jump through some of the financial hurdles to at least get the infrastructure in place.
Yeah, thank you, Mr. Chairman. These are great ideas. And I would really encourage you the time to act is now. The ARPA funds are coming down the pike, momentarily. And so these are some great ideas. Let the governor know.
We submitted comments, Representative Conley, to the governor's office on a lot of these ideas.
Great.
Representative Clifford, go ahead.
Thank you, Mr. Chairman, and thank you so much for a very informational presentation, Eric and Josh. I really appreciate it. My question is going to kind of go back to the billing and collections as far as the options for payments. I'm just curious, are there programs out there that has a specific timeline or restrictions in order to access maybe a payment plan or a sliding fee scale, or, do you have to, is there that timeline? And then I'm just curious, can we do a better job as far as educating the public as far as these programs? Because from what I see and hear, maybe we could do a better job. And I know it's really hard for people out there to have to ask for help. They have pride, they're very prideful and they don't want to ask for help. But, I'm just curious, is there something that we could do policy-wise that could help with the billing and collections part of it? Thank you.
Chairman Baldwin, Representative Clifford, billing and collections it's a difficult one. So the timeline that we laid out for you is kind of an average of what we see from around the state and based off of experience alone. And each hospital in our state probably does it a little bit differently. And some hospitals are more aggressive than others in how they handle that. But one thing that I think a lot of our hospitals do a very good job of, and a lot of times it's our bigger ones because they have more resources, but they're really good at going in and helping to determine whether or not we can get that person on Medicaid or whether or not we can get them on the exchange. We try and meet with them before they have a surgery, if it's an elective procedure, if it's something that they can plan out in the future so that they can take a look at their different options. We also, one of the things we didn't talk about, a lot of our hospitals offer a cash option. If they pay a lump sum, it's better to receive that. If you understand the time value of money, it's better to receive that than to get payments for the next 5 years at $20 a month or whatever. But the one thing that we've always struggled with, and I don't know how to fix it, is patient engagement. And a lot of times it always comes after the fact. And a lot of times it comes way after the fact when the collection letters start to flow in and they haven't gone and met with people. I think from our perspective at our hospitals, some of us could do a lot better job of reaching out. But a lot of times we do that and we don't get any responses until that hammer comes down, which is unfortunate. From a legislative policy standpoint, it might be something that we could consider and talk about. I can't think of anything right off the top of my head. Maybe Josh has, maybe.
Mr. Chairman, Representative Clifford, I don't know. I'm a little stumped on the policy question. I do agree with Eric. I think there's work to be done really from the grassroots, from hospitals and working with our communities to make clear about what their options are, payment when they come into the hospital. And some of our larger hospitals have pretty sophisticated programs where they go to the patient in the room and they try to get them figured out and sorted out before they leave. Because it is, filling out a financial assistance application is fairly lengthy, right? And if you've been in the hospital, you're not feeling well, you go home, maybe that doesn't get done. And so, I think there's probably some educational opportunities that hospitals in partnership with our communities and some patient advocates, I think could do more on, certainly. But from a policy perspective, I'll have to think on it.
One other problem we run into is a lot of times we will meet with the patients, but especially when it comes to the charity care and the federal poverty guidelines, we require financial statements and things. And so the patient will have to go home and gather those. And a lot of times we start down a path and then we just totally lose contact with them, and they're right on the verge of getting what they need. And then no matter how many times we contact them, a lot of times the documentation where we need to take care of the issue never comes forward until later on when it's almost too late. And we do have the ability to pull our accounts back from the collection agency. It's at an expense, obviously. But this is one of those things that I would love to find the silver bullet for, because it would help everyone, both the consumer and the hospitals.
Thank you. Chairman Wilson, go ahead.
Thank you, Mr. Chairman. Eric, I just wanted to go back to the cost report. I know that's a marvel. No, I just have a question. I don't remember from my meeting that some while back how Medicare considers capital expenditures, capital costs, and if those, whether building a mother baby tower or adding a new OR suite, how does Medicare cover those, or do they allow them?
Chairman Baldwin, Madam Chairman Wilson. So capital construction is included, but there's a percentage of the depreciation that's allowed in there. Again, it's allowable versus non-allowable. If they use straight line depreciation, I think it would really help, but that's not really how it's done. So there is a small component of depreciation on capital construction and capital property, but it really doesn't tip the scale as much as I think it could if it was done appropriately.
So Mr. Chairman, if I could have a follow-up. One of the discussions we had, I guess it was in 2019, I can kind of visualize us sitting in Evanston. Ways in which the state could assist with costs, assist with, reducing the fixed costs when it's spread out over not very many people. And I know probably Representative Hallinan, I don't know what he certainly had an inquiry about certificate of need. But one of the things we asked about in 2019 was whether it would be helpful to hospitals to basically get loans from the state for capital costs. And I know, certainly some of the hospitals have available the revenue bonds and that sort of thing. Just what are your thoughts on anything that the legislature could do to assist hospitals in reducing the fixed costs, like the capital expenditures and the equipment?
Mr. Chairman, Madam Chairman, that's a great question that we've talked about quite a bit, and one of the things that I know we've relied on for years, but seems to really taken a beating, is the the ability for us to access money through the mineral royalty grants through the SLIB board. We're being told there's really no money there, but that used to be a 50-50 match that we would use. A lot of our hospitals would use for some construction and like to acquire half of an ambulance, things like that. If there were, I think maybe, and we've talked about certificate of need.
I'm sorry, I can't hear you. I don't know if anyone
think
can hear you, but I lost you.
Eric froze up, I believe. I don't know if you can hear us or not, but you're frozen. And it's not the movie Frozen, you're just frozen. I'm assuming everybody else can't hear them as well.
Yes, Mr. Chairman, this is LSO and we can't hear the hospital association either.
Yeah, they've also disappeared off my screen. Oh, they're coming back on. They lost service, but they're on the way back. I just got a text, so. Hang tight, they'll be back with us shortly.
Well, Mr. Chairman, while we're waiting for them to come back, I know that there was some concern expressed in the Senate committee early on in session about whether hospitals were getting CARES Act money that wasn't really needed and were they spending it on things that they shouldn't be spending it on. And I'm wondering if there's any input from the senators as far as capital expenditures for hospitals, just so we might all share their thoughts while we're waiting for Eric.
I think my concern, Chairman, is not so much about new expenditures. My concern is what we've spent and will they be able to maintain services and maintain those things once all this funding disappears, right? That was my concern. I don't know if the other senators on here have anything to add on to that, Senator Furphy or Senator McEwen or Senator Bouchard. Go ahead, Senator Furphy.
Yeah, thank you, Mr. Chairman. Yeah, I know our local hospital, it's extremely important. As I pointed out, they're in competition with hospitals to the south of us. So they do need to make capital expenditures to keep the hospital relevant and add new equipment and keep the facilities top notch to be competitive. So it is very important, those capital expenditures.
Madam Chairman,
I see Mr. Bully back on. Go ahead, Senator McEwen, your thoughts.
I'm pretty sure I'm remembering this correctly. It wasn't necessarily an issue of the add-ons, but when they did the add-ons with the CARES Act money, they added way more than they had money to add. And then they came back to get the rest. Isn't that what you saw?
That was one of the things yeah, that is one of the things that we discussed. And it's something certainly we get to the special session, that's going to be something we discussed, but that was one of the issues in that meeting. You're exactly right.
Yeah. And Madam Chairman, I think, at the end of the day, if you can afford a Volkswagen, you don't go buy a Ferrari.
Right.
Thank you.
Very good. Thanks, Senator McEwen. I see Mr. Bully made it back on. You remember which question you were answering, Mr. Bully?
Mr. Chairman, I was talking about Madam Chairman's question about certificate of need and borrowing money, but if I could, I'd like to respond to Senator McEwen. Our hospitals did not ask for additional money. We asked to be paid for what we were approved for, but it took longer than December 31st to get completed. There were no applications asking for money that wasn't already approved by the SLIB board during their different meetings from July through November. Okay, Chairman Wilson. So if we could
Madam
borrow
Chairman,
money,
I'd like to respond to that.
Okay, we'll go ahead with the response quickly. Go ahead, and then we'll move ahead. Go ahead, Senator McEwen.
Eric, it was a question, not an indictment. Thank you.
Okay,
I only heard
Okay.
part, I'm sorry.
go ahead, Mr. Boley. Go ahead and answer Chairman Wilson.
So Chairman Wilson, if there were a way that we could potentially borrow money at a low interest rate, I think that's better than what we can sometimes get. But I think the overall issue is the actual paying for the, a CT machine's $1.5 million, I think, to start for some of the lower end ones. And some of our facilities just don't have that ability. A lot of the vendors will actually put them on payment plans, allow them to pay over time. But the volume still seems to be a problem. I think there's some creative ways we could do it, though. I'd be interested in talking with you about maybe some ideas to see if we can put something together. There are certain requirements also that we may have to take a look at as far as what, especially our critical access hospitals are allowed to do, as far as lines of credit and different things like that under statute that we may have to visit to make sure that we're in compliance, or we might have to tweak those to allow a new program. And I apologize, Senator McEwen, I only heard part of it, but I just wanted to make sure that you knew we didn't ask for any money that we hadn't already been approved.
Okay, very good. Representative Hallinan, I'll bet your hand's getting tired. Why don't you go ahead, sir?
Thank you, Mr. Chairman. I would like to address the question that Representative Flitner brought up about the number of CAT scans that are close together in her community. I really think that we need to look at this certificate of need again. And I would like to work with Mr. Boley. I think Mr. Boley is a very sharp guy and he's got a lot of good ideas. I'd like to work with him on that issue. If there's a way that we can finance or not finance these kind of capital expenses. I think the presentation that was made by the two gentlemen from the Wyoming Hospital Association pointed out the costs that are breaking the hospitals. And I think it was a very dreary presentation because there was costs everywhere and there was very little ability that was presented to reduce those costs. But I think the certificate of need or something like that is a possibility that we could use to reduce some of these costs around the state. So with that in mind, I'd like to hear from Mr. Boley what ideas he has in that regard, as I'd like to work with him on that. Thank you, Mr. Chairman.
Very good. Sharp dressed man, Mr. Boley, go ahead.
Chairman Baldwin, Representative Hallinan, I appreciate you saying I'm sharp. I feel like a dunce for jumping in the middle of the wrong conversation. So I think you make some good points. We have talked a little bit about this, and this topic actually came up in our healthcare, our governor's healthcare task force meeting as we talked about costs of healthcare in our state. And one of the things that we always run into is the free market conversation, and a lot of this imaging and things can be done in a cheaper setting because of the fixed overhead that an imaging center can have much lower compared to a hospital. I think it would be interesting to see how we could craft this and how we could take a look at it. But I would absolutely be willing to see if we could come up with something that works. And I'd have to do some research, see if there's anything that's been done around the state similar to this. But I know this is an issue in many communities and many states. The other thing that we have, our insurance companies, it's the right thing for them to do to try and reduce costs. Is a lot of times they'll direct their insured to go to a cheaper setting, which makes sense from their perspective, but it actually diminishes the total number of patients that are seen that could help spread that cost. And so we have folks that are going and getting medical imaging at medical imaging centers and other things, as opposed to our hospitals, and it actually drives the cost up in the hospital setting, but it saves the insurance company money. So that's another thing we'd probably have to address as well.
Thank you. Might I throw one more thing into that conversation when you two get together over coffee? And that is, I would consider the new freestanding imaging centers. I think that's a part of that conversation. That's becoming more common in Wyoming and other states as well. So I just throw that out there because I've been in that conversation recently, and that's becoming a very big issue. So that said, any follow-up, Dr. Hallinan?
No, Mr. Chairman, I think that I presented my point of view on that, and I'd like to work with Mr. Boley on this issue. So thank you for this opportunity, Mr. Chairman.
Thanks for those thoughts. Representative Ottman, go ahead.
Thank you, Mr. Chairman. And I also want to thank the presenters. I never cease to learn so much when I hear the Hospital Association come. What I really like about today, although there for a while I was thinking, oh, gee, it's warm and long. But one of the things that I'm noticing is that we're voicing a lot of issues, but I'm also hearing, okay, what can be done? What can be done? What can be done? And I think that is wonderful. So I have a couple questions, and please forgive me if you said it and I missed it, but I'll just list the questions, and then if you would respond.
Representative Ottman, do you have something going in the background there? We're getting an awful lot of feedback from somewhere.
Yes, I'm sorry, just a moment.
And now you're muted.
I'm muted to get rid of it. Yeah. Okay. Thank you. First off, are the doctors and the doctors' offices and the hospitals, all the coding providers, are they all using a uniform coding system? Okay, because I know there's different schools that people go to and things like that to learn coding. So that was number one. Number two, is there a patient truth in lending? I know that just a little while ago, someone said about, or you did, Eric, about speaking with the patients and going in there and talking with them. One, it's been my experience that's a good thing. But two, oftentimes when the patients are spoken with, they are still under the effects of anesthesias and different things like that, and they have no idea what they were told or what they've said. And if nobody's in there, nobody ever has that information in the future. It's unknown. Third, as far as the recruitment for doctors and things go, we had that question earlier. There was a chart from one of the presenters early on that had Wyoming at the very top there, as far as the way I read it, as far as having very good pay for doctors that are in the state of Wyoming. We had that little box at the top. And so I realize there's a lot of things, you mentioned it, bringing in the spouses and employment and benefits and all that stuff. But I don't see that we're not trying in that area. So there's got to be some things, maybe the other senator's thing about a Volkswagen or a Cadillac or whatever. The next thing was, and I think you're starting to address this, but with, I know, who is the organization that you keep talking about, the CMH or CM?
CMS?
CMS, yes. who are they? How are they established? And can we get out from underneath them, or is that federal that goes along with the money? Because why I'm asking that is there a way to eliminate some of the regulations and requirements? And this may go along with the last representative's comments. So anyway, that's just some of the things. I really appreciate that. And I know it, being from Fremont, this is an ongoing issue and lots of little spider webs in there. But I appreciate your time and thank you.
Go ahead, Eric. Tell us about CMS.
All right, Chairman Baldwin and Representative Ottman. CMS is the Centers for Medicare and Medicaid Services. So it's a federal government, and there is no getting out from under them. They are the heavier than 1,000-pound gorilla. We have to do everything according to them to have our licenses for our hospitals. And so we've talked a lot of times, and I've had conversations with Senator Bouchard, as a matter of fact, over trying to find ways to get out to do away with rules and regulations that are burdensome. The problem is that CMS just continues to pile them on, and so the state laws really don't supersede anything that's done. If we're out of compliance with CMS, they'll quit paying us. They'll quit allowing us to admit Medicare patients. They'll penalize us. So unfortunately, that's the federal government's arm of healthcare. And so we're kind of stuck dealing with them. As far as uniform coding, the CPT codes, the ICD-9 codes, the HCPCS codes, the things we talked about, they're all very uniform. And no matter where a coder goes to get their certification, they're taught to do it the same way. And the variances there really come in with the how accurate the dictation and the information they receive from the providers, and their ability to truly identify what the actual diagnosis is. And again, this all has to go, at least in this particular case, when we talk about CMS, it goes to them, and they're really good at denying any claims that have any variances on them. And so a lot of times we spend time in that collection process refiling claims over and over again until we can get them cleared. But there is uniformity in the way that the coding is administered. Definitely understand your question about a patient being talked to when they're coming out of anesthesia. We normally try to meet with them either before or after, and we normally provide documentation with them that clearly outlines what the options are available to them. And there are usually contracts that are put in place. And we rarely do that, I would hope anyway. It shouldn't be common practice to do it while they're under anesthesia, but they do have it in writing, and it's not like they have to sign it immediately. There are several weeks while we wait to figure out what the payers are going to do before any action's taken. And you made a really good point. I think it was in the Department of Health's presentation where they talked about physician salaries and wages. And there are a lot of different studies out there. There are different groups that put out by specialty what the average wage is or earnings for different specialties, orthopedic surgeons, family practice, PAs, whatever it might be. And the reason that our numbers are so high is because we're paying a lot of money to get them here. And a lot of our hospitals and a lot of our communities, we're paying like the 90th percentile in the country. And that's what we're having to pay to bring them in. And so it obviously helps increase the cost of healthcare, but to get providers into our state, that's what we're having to do, in addition to recruiting their significant others to want to live in those communities. And the problem we're running into, and like I said, I was at a WWAMI dinner last night, very few of those students are really looking at going into family practice. They're all looking to specialize. And we're really going to be facing a shortage nationally, but I'm even more fearful here in our state. We're going to be facing a huge shortage of primary care family practice providers, which is probably the most important. I'm going to be unpopular with some doctors, but I think to a certain degree we've almost done a reverse incentive where family practice is so important, but yet they they get reimbursed at a lower level than some of the other specialties. And obviously those other specialties take really specialized training and experience, but to a certain degree, I don't think we reward our family practice docs enough to really entice them to be in the workforce.
Let me just shine a spotlight on there for an example, because it keeps going through my mind, and that's with the ICD-10 coding. And it may help you understand a little bit better and why things get turned down. And just let me give you an example. If you come in to see your doctor, your PA, your nurse practitioner with a sprained ankle, when they document that, when they put that in the chart, not enough to say that they sprained your ankle. That'll get turned down. You first of all have to say how you sprained your ankle. Did you fall? Did you trip? Did somebody trip you? Did somebody push you? Secondly, if you fell, from what height did you fall? Did you fall from a standing height? Did you fall off a chair? Did you fall off the Humpty Dumpty's wall? Next, they want to know where that fall was. Were you getting out of your car in the driveway? Were you at the gym? Were you in the living room? Were you in the bathroom? Next, they want to know all those, they got to know all those things. If you turn it in now, it's still going to get denied. Now you turn it in, they want to know specifically what tendon you sprained. You know, there's a lot of tendons in the ankle, and they want to know specifically which one you sprained. It's a nightmare. And what that adds on to things is, in order for that practitioner to document that sufficiently so that it gets coded correctly and gets accepted and we get paid for it, it takes time. It's not as simple as, putting in there a sprained ankle, bill for it. Now you're taking an extra however many minutes or at times half hour or an hour to fully document that. That's time out of that practitioner's office. He or she can see less patients, and hopefully everything gets done, but it's a vicious circle. And that is, the coding has become a very difficult thing to do. I know that practitioners, providers generally get the brunt and we get accused of doing a bad job, but the fact is it's very difficult, and it's not an easy, and it gets more difficult with the inception. When we went from ICD-9 to ICD-10, it got 10 times more difficult. And that's just one of the many examples. When you describe a fractured arm, you got to say which bone, how it's fractured. Is it diagonal? Is it transverse? It's very, very, very complicated, and consequently takes more time. The EMR, as opposed to being a very beneficial tool and being a good thing, has turned out to be really a handicap. It takes more time, and actually has created somewhat of a problem as opposed to what it was supposed to do. I have a very popular colleague that does presentations that talks about doing check boxes all day and not getting paid for it. So he really doesn't get to see a lot of patients. He spends a lot of time checking boxes on a computer. So anyway, I just wanted to shine that highlight out there. I see that Representative Romero Martinez has got his hand up. Go ahead, sir.
Thank you, Mr. Chairman. And I had a few points to make. And regarding patient engagement, I wanted to talk to the group about patient engagement. We had mentioned it a little bit earlier. I know it was a little bit farther back, but I guess I want to volunteer for trying to help out with patient engagement. If there's a way that I can assist in any way, shape, or form. I think there's various nonprofit organizations that would be interested in that. I think we also have to take into account the history of our town, the foundations of Memorial Hospital, the foundations of what was once DePaul Hospital, and where it's at now. And I just kind of wanted to put that out there. And I think this question was already answered, but in regards to, let's say you have a 24-year-old young person who has $50,000 of uncompensated care, but you've reached out to them, but they're not, meeting you halfway. They're not meeting with, so it goes by, goes by the wayside. What can we do to engage the faith community, the nonprofit community? Is that something already being done? Is there already an existing outreach for that. And so I'll just start with those two concepts first, and if there's any feedback from the Hospital Association.
Go ahead, Mr. Bully.
Chairman Baldwin, Representative Martinez, again, great points. As far as patient engagement, I think that's an important step, and I think it's important to find ways to do that. We would welcome any help in helping people become more educated and involved in their healthcare. As far as your other example, I think maybe Representative Wharf would be a great one to talk to. He's provided testimony on the last couple of hearings on Medicaid expansion on a situation in his life. But each community is going to be different, the way they reach out, the way they help one another. But Representative Wharf has shared a personal experience that might be a good way to at least start the conversation. And so I would suggest maybe talking to him about what happened with him and his family.
Very good. Further questions, committee? And I would relate something that we learned in Revenue Committee this week is that subcommittees are a bad thing because they cost money. Working groups are not a bad thing because they're voluntary. And so when we're talking about those kind of things, that may be something we talk about doing down the road and forming some working groups for those who wish to volunteer to do those things. So that being said, are there any further questions, committee? Seeing no hands. That looks very good. Thank you very much, Mr. Bowling, and thank Josh for us. He disappeared, but I bet he's not very far away.
He's right here smiling at me. So thank you, Chairman.
He always smiles. Thank you very much for coming to the committee and doing a presentation for us. We will be seeing you next month, likely.
Our pleasure. Thank you.
Oh, there's a hand up, so don't run away. Representative Conley just put her hand in the air. Go ahead, Representative Conley.
Thank you, Mr. Chairman. It isn't a specific question for Josh or Eric, but it is a comment because I just got a comment, honestly, from somebody in the public who wanted to be able to comment on the presentation or ask additional questions. And I don't think that's possible. I think that this was simply kind of informational with very specific speakers. So I would just encourage anybody who is listening, who does have comments that they want the committee to hear or to understand a different perspective, you could certainly write to the committee. That's certainly possible, and I would look forward to that. So thank you, Mr. Chairman.
Thank you. And I would add that on the legislative site, the option was out there for anybody that wanted to apply to testify, and that was open. But we didn't anticipate that there would be a lot of public participation, being an educational time. But certainly if there's somebody out there, and Katie can probably tell us better, if there's anybody signed up out there that wish to comment or talk to us, we certainly have time now. We're about right on schedule.
Chairman Baldwin, this is LSO, and we do have one person in the waiting room who registered in advance. But I do see Representative Romero had his hand up, so maybe you want to take his, Representative Romero Martinez, maybe you want to take his question first.
We will do that. His hand is not bright yellow. We need to get him a bright yellow hand so I can see it better. Representative Romero Martinez, go ahead, sir.
Thanks. I had a thought here. I don't know if anybody's been to the hospital in Laramie to the oncology department, and I'm sure you guys have. There's this mural of the Hospitalers, one of the original creators, obviously, of the hospital. That's where we have the name hospital. If anybody's seen that, and I recall talking to a nurse about 14 years ago, working on a specific health initiatives, and she was talking about the original shape of these hospitals, and this is going towards infrastructure. And I wanted to bring this issue back slightly. It was mentioned earlier by one of the good representatives about working with the elderly and space within centers for care. They originally used to set up these hospitals. Obviously, there was a castle. Then actually the church was inside the castle, and then they had the hospital. Inside the hospital at the very center was your prenatal, basically, and elderly care center, and that was the bigger center. And then on the outskirts, if you were a warrior and you lost an arm, you were on the outside, because if you could still fight with one arm, you would fight with one arm. So more of can we maybe, is there something we can do to look into how these centers are built? I guess what I saw kind of a connection during, through this, year of pandemic of infections within elder centers. And I think part of that is you're packing it with, not you, but we as a nation in general are packing them in at like sardines. And what can we do to make those infrastructures better and address, from an ancient perspective, how we were protecting the most vulnerable at one point. And now, I mean, we're still doing the best effort, best of our ability, and we're moving forward, of course, but maybe we could look at infrastructures that are, with modern, I mean, look what we do to buildings now. We can make them safer, cleaner, better. I digress. Just a couple of thoughts in relation to that. Thank you.
Very good. Mr. Bully, do you wish to comment on that?
Well, Chairman Baldwin, Representative Martinez, there are some really good examples of, especially in long-term care setting. We have our greenhouse model up in Sheridan, which, it's built in pods as opposed to just one big room. The other thing, again, as we look at infrastructure, we have aging facilities all across the state, and in long-term care, we may have more than in hospitals. And most of it is either semi-private room, or some of them, you still have 3 residents to a room. There was some way we could use the ARPA funding to create private rooms and then put in adequate air handling units so that you could create negative pressure rooms and help them isolate in comfortable setting. I don't know. I hope this is the only pandemic I ever have to face in my lifetime. We can wait another 100 years for one of these, as far as I'm concerned, but there are ways I think we could utilize it as infrastructure ways to improve what we have. But I would use the greenhouse model. I think that's what they're planning on doing, at least to a certain degree, at the Life Resource Center and also up at the new VA nursing home in Buffalo. And I think it's a really good model that for a whole lot of different reasons.
Thank you, Eric. And that is something that this committee has toured, the greenhouse model. Like Chairman Wilson can correct me if I believe it was in Buffalo or Sheridan. I don't remember where. They all fade together now. I honestly don't know where we were. Anyway, that's a very good suggestion and a good idea.
Chairman, if I could just make one last comment, I just want everyone on the committee to know that this is National Hospital Week and also National Nursing Home Week. And I'd be remiss if I didn't just mention that we have healthcare heroes in every one of our communities. This has been one of the most challenging years I think any of us could ever anticipate or face. And I am extremely honored and proud of the incredible people we have in every one of our communities and for the sacrifices they've made to keep all of us safe. So I hope you'll recognize them and celebrate Hospital Week with them. They're incredible, and we're blessed to have them.
Thank you, Mr. Bully. Donna, is that person still out there? If so, let's bring them in.
Okay, it's Donna Sheen from the Wyoming Children's Law Center. I'll admit Miss Sheen.
And I see we have one person at the Capitol too, I'm told by Katie. Let's go ahead and bring in the one online first. There she is, Donna Sheen. If you can hear me, go ahead, ma'am.
Thank you, Mr. Chairman, members of the committee. I'm Donna Sheen, Director of the Wyoming Children's Law Center. I know you've had a long day, so I'll make my comments very brief. Our center's mission is to essentially advocate for youth and vulnerable adults involved in legal systems and promote the use of non-legal avenues to support children and families whenever possible. My comments will surround concerns about the overuse of residential programs for children, especially our CHINS and delinquency systems. Wyoming continues to have some of the highest confinement rates in the nation. We believe the main reason for this costly and often unnecessary placements are twofold. First, the lack of community-based alternatives. And second, the lack of objective standards to guide placement decisions in court proceedings. As the Department of Health pointed out earlier, our children have constitutional rights under Olmstead and other legal precedents for treatment and services provided in the least restrictive setting, which should be by and large in our communities. Yet I believe DFS reported that 90% of delinquency cases earlier today that they involved a placement. As you know, Joint Judiciary will be looking more closely at our juvenile justice system. However, I want to encourage the committee to also focus some attention on related issues that may be more appropriately based in this committee that also need to be addressed in sequence with juvenile justice. And specifically, there are 4 areas that I would suggest the committee may want to look at during this interim as part of your, I think it was 3, 4, and 5 topics. First, consider clearly defining when a delinquent and CHINS youth is eligible for placement. And perhaps more importantly, when the placement is not appropriate. Many youth are placed in the Wyoming Boys and Girls School or other residential treatment facilities as a result of probation revocations because of a probation violation like a truancy or failing grades. These circumstances do not present any significant risk to the community and also don't warrant removal to effectively address the behavior that's the problem. And the research is now very clear that these types of placements are very harmful and ineffective, and they actually increase the overall risk of recidivism and school failure, not to mention waste taxpayer dollars. Second, I would ask that you clarify the definition and the purpose of a CHINS petition to either require parent consent clearly or to establish criteria for when the court can proceed without a parent's consent so that a parent is offered some basic due process rights before control of their child is taken away from them. And also consider ways to amend our CHINS statute so that parents can obtain necessary mental health care in a residential setting without having to give up legal custody of their child to the state. Many other states have found ways to accomplish this, and I believe Wyoming could do that as well. Third, I would like the committee to consider prohibiting the use clearly of Title 25 on children. A Title 25 action against a child, in essence, takes legal custody from their parent without affording the parent any opportunity to exercise their constitutionally protected due process rights. They're also denied the opportunity to determine and consent to the treatment that may be necessary. And I would just let the committee know that if a parent is denying necessary medical care at a medical facility, then the appropriate legal action is a neglect action in juvenile court for medical neglect. And this process still allows for an emergency custody, but it also affords parents their due process rights. I think the use of Title 25 in CHINS is more accidental and lack of training, but we see it happening quite a bit, and it is a concern that we see regularly. And finally, I would first commend DFS for the efforts in the Family First Initiative. It's very exciting and a welcome shift from in our system to better serve families. There are some positive changes we're excited to see. However, the loss of Community Juvenile Service Board funding will be devastating in many communities and has the potential to push more youth into placements, undermining some of the benefits of Family First. There is quite a bit of leeway in the federal legislation for states to be very expansive in their use and definition, especially of an at-risk youth, for purposes of providing those tertiary and prevention services. So we encourage the committee to monitor that closely and try and encourage that definition to be very broad, where more youth can be served in their community under Family First, especially in the delinquency and CHINS population. And also, I would just encourage the committee to support the restoration of the Community Juvenile Service Board funding. It was a very critical piece of encouraging community-based services that were reducing placements before the funding was lost. So I will send the committee more written details. I know I ran through a lot of really technical things, so I will follow up with written recommendations, but I would be happy to answer any questions the committee may have right now.
We appreciate those thoughts, Ms. Sheen. And if you would send just a general email to the committee, and those are things we will think about and things we will talk about down the road. No doubt. Are there any burning questions from the committee? Senator Bouchard, I believe, has one.
Thank you, Mr. Chairman. My question is, it seems like there's a monetary part in here where sometimes kids get in placement, and it's really hard to undo it. I mean, I saw things that happened that we brought up in the past where foster kids were actually placed in a foster home, and then they had to go into mental health treatment. The foster parents didn't want them back, and this thing just went on to where there was just way too much treatment was actually doing harm. But at some point there was that monetary incentive that keeps them in the system, and I'm trying to figure out how do we stop that kind of action. And it seems to me, even when you talk about it, it's something that people don't want to talk about. So that would be my question.
Thank you. Ms. Sheen, go ahead.
Chairman Baldwin, Senator Bouchard, I think that there is some truth to that. I believe what happens sometimes is private facilities, and I didn't bring this up, but I probably should have. There's pretty much a lack of standards also for private residential treatment facilities in Wyoming. We have some very limited regulation that cover just generally childcare, but they don't really monitor what kind of treatment is happening at those facilities. And we have a couple, well, actually only one now that was a for-profit facility. And so you can imagine if you have a bed to fill and you can say a child's, not progressing, he can stay a long time. And so part of what I think this committee should look at is whether there's some objective ways or controls to put in place to ensure that treatment is medically necessary. When a child is at a psychiatric residential treatment facility that is under Medicaid, they are receiving Medicaid-based mental health services, there is that oversight. However, some committee members may not be aware, but quite a while back, many of the residential treatment programs that now operate in Wyoming do not meet that level of care, so they are not necessarily given that same oversight about mental health treatment. And so I do think that also is an area where the committee may want to focus some time and energy.
Very good. Chairman Wilson, go ahead.
Thank you, Mr. Chairman. So, Ms. Sheen, my thought is kind of on the opposite side, and I'm wondering, about the availability of foster homes, community homes with families rather than group homes. And I know there was some concern about that with the Family First legislation and all. I mean, certainly from my point of view, and I hate to admit this, but being a foster family seems a very onerous thing that I would not want to do. And so are there national figures that suggest sort of a, number of foster homes per capita kind of thing? I mean, is this just a problem everywhere? Is it a particular problem in Wyoming? Any thoughts on that?
Go ahead, Ms. Sheen.
Baldwin, Chairman Wilson, it's a convoluted answer. I'll try and make it brief. I think that foster care numbers, I think DFS would be better at maybe talking about where they fall within national averages. I can tell you as a former foster parent that it is hard. And part of the difficulty is in taking in older children. So I believe part of DFS's challenge that's very hard is recruiting foster parents for older adolescents. And often that's why that placements end up being in more restrictive settings for them. I do think, and I want to commend DFS, their recent changes in allowing the crisis beds to be utilized more effectively by just having the beds funded without having to open cases is going to be a really big help for families. And my hope is that that will reduce the need for any kind of court proceeding when you don't need to take legal custody of the child, when they can just utilize a crisis bed voluntarily. My hope is that that will really help with this problem.
Very good. Follow up, Senator Bouchard.
Thank you, Mr. Chairman. I mean, the cases I was addressing were kids that went to a foster home. The foster parents basically wanted to turn them back to somebody. They were still being stipended as parents in our system, but yet the kids were in treatment for a long enough time where the providers were saying this is doing more harm. And so it seemed like there was just a lack of oversight. I mean, when do we take action and try to get the kids out at all costs? I mean, they should have broke the relationship with a foster parent, or that relationship, so we can move backward. So I have documentation on it. So I would be glad to share it with you, Nasheen, and that way we can maybe look at what should have been done, and maybe we can work on that offline.
I sense a working group coming up here. So any reply to that, Ms. Sheen? Go ahead.
Chairman, just briefly, I'm happy to take a look at it. I didn't mention that our center also provides direct legal services to families. So we do have a lot of families that certainly would be able to share their experiences, and they do vary, but certainly there are some very hard stories and difficult situations like that where we see the system break down for some reason, and it can be different components of the system that maybe aren't operating well, but I would welcome your involvement and discussion about that.
Very good. Committee, the finish line's in sight. Katie offered up if there's somebody at the Capitol. I suspect they're wearing blue and sitting in the seat of honor at the committee table. If we can go ahead and live their mic and bring them on.
Good afternoon, members of the committee, Mr. Chairman. My name is Heather Roday, and I'm representing Blue Cross Blue Shield of Wyoming today. We're really glad that this conversation is happening today. Health cost conversation is incredibly important, as I think we all know that Wyoming has some of the highest healthcare costs in the country. We as an organization are always working to help make it more affordable, not only for our members, but also for Wyoming residents. Just wanted to offer some clarifications for some things that have been mentioned today and earlier this week. So there have been some passing mentions of payers, and just wanted to remind you all that Blue Cross Blue Shield of Wyoming is a not-for-profit. So in a previous slide today, it made it look like we were for-profit, but we are actually not-for-profit. We are a Wyoming-based company. Earlier this week, it was maybe guessed that we were from Tennessee. So all of our folks serve our Wyoming residents and our neighbors, and we're actually celebrating our 75th anniversary. So we are an independent licensee of the Blue Cross Blue Shield Association, and one of two companies that's offering policies on the exchange, but we are one of many companies in the state that are offering health insurance. So we have a face, right? And earlier when Mr. Boley said that hospitals are highly regulated by a little organization called CMS, would also be happy to chime in that the health insurance industry is incredibly regulated by those folks as well. So when we talk about the payers and their role in healthcare in Wyoming, we are happy to be at the table. We have sat with our colleagues with the governor's healthcare task force and continue to try to make a difference and welcome further conversations. So you'll be seeing a lot of us, and just wanted to make that introduction again. Mr. Chairman, I stand for any questions.
Thank you very much, Heather, and committee. That's a face that you will be seeing a lot in the future. She will be at many of our meetings. Do we have any questions for Heather? Heather, I think you're off the hook. I don't see any hands being raised, but thank you for speaking with us, and we will be seeing you down the road.
Thank you, Mr. Chairman.
Committee, we came in under the wire. We didn't finish a lot early, but yeah, a little early. We'll take what we can get because that's fairly uncharacteristic of the Labor and Health Committee. So I appreciate it. I'm sure Chairman Wilson can share some times with you that this committee has gone lengthy hours into the night. Tonight's not one of those nights. I would throw one final plug into the committee. I often offer folks with the ambulance service, with the hospital, with the fire department, what we like to call ride-alongs. I would encourage committee members to go to your local hospitals. I would encourage you to go to your local DFS office and kind of get to know some of those folks on a personal basis. And you might hear some stories that you didn't hear today, and they'll bring some additional knowledge to you. I think that's an important feature, and I certainly think that's important. If you have that opportunity to get to those nursing homes, hospitals, you can ride along in an ambulance if you want. I don't like, if you get seasick, it's not a good opportunity. Otherwise, if there's nothing else from Chairman Wilson, I believe we'll probably move on. We will be meeting in June. I don't remember the dates. Chairman Wilson, do you know the dates?
Let me just stand up and look at my calendar here. It's June 10th and 11th, and committee members, especially those of you who are new to the legislature, don't forget to make yourself a hotel reservation. It's not that crowded in Riverton, not like going to Lovell or something like that, but remember, you need a hotel room, so you'll want to drive up Wednesday, and depending on where you live, you may or may not leave Friday night or Saturday morning or something like that. Chairman Baldwin and I will be working on the agenda. We expect 2 full days.
Full days, very good accommodations there at the college. That's where we just did revenue. Very good accommodations, good facilities, some good places to stay in town. So good places to eat in town for that matter too. But anyway, if there's nothing else from committee members, we will be seeing you on June 10th and 11th. Oh, Senator Bashar, he's going to share some wisdom. Go ahead.
So I have a question. Hold on, I got feedback here. Good. So I have a question about using that college. You know, we showed up to that meeting, Representative Worf and I, and we stood in the back room, had 12 chairs in there. I mean, I think it's the most offensive thing to not only legislators, but the public, that we have this in a place that has different set of rules than legislature. We spent millions of dollars with this building that we're in right now to make the government closer to the people. And we're in some little room in a college where we have to abide by all these rules. And like I said, it's just not fair to the people. It's not fair to everybody involved. So I'm just wondering why we're doing that instead of why are we doing this like we're back in the horse and buggy days when we got this big building. We're sitting at this big committee room right now where the people could come in here. So that's my question.
I'll just say, I don't know what room people were at there, but I know when we met in Riverton 2 years ago, we met in the health sciences room, which had a very large, as a matter of fact, Senator Bouchard was there. You remember that room we were in? It had a lot of seating. Were you in that same room?
No, we were in the intertribal room, Chairman Wilson.
Madam Chair, Mr. Chairman, the rules there are they won't put you in a bigger room, so you can't have people in that room. So they're still keeping it social distancing. So that if somebody rolled a chair into the room, they were saying, no, you can't bring that chair in here. So I mean, I just don't think it's a proper place for the people.
Interesting.
This
We'll check with
Well-
LSO on that topic. That's a good warning.
And I would counter that a little bit with, this gives an opportunity to those folks in Riverton that otherwise wouldn't be able to see us, but it's a whole discussion, and you bring a good point to the table, Senator Bouchard. That's a good point. And we'll work with it and see what we can do.
We'll give
Committee,
them a poke.
I hope everybody learned something today. If a little bit or a lot, and we appreciate you taking the time to be here. Any of you senators or representatives from Cheyenne, if you run into Senator Hutchins, tell her what she missed. And hopefully we'll get everybody. If you were a part or got to watch the revenue meetings the last couple of days or this week, you will notice that in-person participation is much better than the virtual, and it does present a challenge. So we highly encourage committee members to make it in person if at all possible. It's permissible to do some online stuff, but if it's possible, please be in person. It's much better and it's much more effective. With that said, I hope you all have a good weekend.
Mr.
And,
Chairman,
yeah.
I just want to thank both of you for making this day available to all of us. It was a good learning experience. So thank you for making this arrangement.
It was educational for all of us.
Yeah.
Noting that we left out a whole huge segment of our topics, and that we didn't talk about labor a lot, insurance, and we have another whole segment that we will be talking about during the interim. So
We have 6 more days.
yeah, so you'll be
And
here. Yeah,
certainly thanks to Department of Health, DFS, and the Hospital Association for putting together the presentations. We specifically asked them to do things that would be downloadable by other legislators, could be reviewed later, that had most of the material on the PowerPoint so that people could look at it at their leisure. I know I did receive response from other legislators who are not on this committee that just want to know more about the subject matter. And if any of you, for some reason over the interim, have some community presentation and they want to know about, I don't know why they would want to know about Title 25, but maybe they would, or what's Medicaid, feel free to use that information again. So
and
all I've
a
got.
final thank you to all those people along the bottom row of my screen, all those LSO folks. They're the heroes behind the screen, and they did a great job again today, as they always do. So thank you,
X Club.
Donna, Elliot, John, and Katie. Thank you very much, and we will see you all in June.